Recording has started. So we're going to start today talking about the principles of goniometry and the principles of manual muscle testing. Out of all of this class that you're going to be going through with kinesiology, this is the bread and butter of this whole class. I mean, the rest of the class talking about gait, talking about posture, talking about a few other things. Yeah, it's important, but most of this class is geared towards working on goniometry and manual muscle testing, because those help us provide an objective finding on how our patient is doing, right? So we're going to start talking through it a little bit. So again, you're going to see that we keep hitting these terms over and over and over again, right? PROM, AAROM, not AARON, that's a different skip. AAROM, AROM, and FROM, right? So passive range of motion, active assisted range of motion, active range of motion, and functional range of motion. By the end of the semester, this should be like you wake up and have a nightmare about these terms, right? Also, we're going to talk about things like bony lockouts, right? These are joints that have the ability to lock into full extension or flexion and locks in based on their bone-on-bone intersection. The best example of that, obviously, is the elbow, right? Resistance, when we're talking about this, is going back to that whole lever police type thing again. Resistance is that concentric force that acts in the opposition to a contracting muscle. So right now I've got a digiflex because this is my exercise right now, right? When I squeeze down, I am concentrically contracting my finger flexors, right? The resistance is the springs in this that are resisting my concentric contraction, right? Line of pull, when we are providing manual resistance. So when we're physically doing manual resistance against a motion, we want to make sure that our manual resistance is in the line of pull of the muscle. So if I'm doing something against the bicep, I want to make sure that my resistance runs vertically with that bicep. We wouldn't want to push this way when we're trying to contract the bicep because that's not the line of pull of the muscle. So you've got to go with the line of the pull. Break. This is the point where the range of motion, where the muscle is most challenged, and that's the point where the patient is going to be asked to hold, right? We're going to talk about break tests, which we basically mentioned last semester in anatomy, right? And it's a position where the PTA is going to ask the patient to hold and not break with the resistance. So that's where we tell them, okay, hold on, 3, 2, 1, good job, right? The break test is the most common procedure used in manual muscle therapy today, or manual muscle testing today. Active resistance is the application of manual resistance against an actively contracting muscle group. The therapist gradually increases the amount of manual resistance until it reaches the maximum level the patient can tolerate. This also plays into those isokinetic machines as well. I think I mentioned in the previous lecture talking about that tonal machine, which I'm kind of enamored with. If it wasn't for like the fact that it's like $4,000, I may be interested in one of those. But an isokinetic machine is one of those machines that will keep providing you with resistance and resistance until you hit the point where you fatigue or you are no longer able to resist that machine any longer. If you're interested in getting into therapy that deals with work hardening or improving work conditions and stuff like that for patients, you'll see a lot of these isokinetic machines. The big one for me was the one when they tested my shoulder and my arm after I broke my neck. And it was always amazing to see the difference between my left arm and my right arm. Now, I've worked a lot since then, and I do have some left arm strength, right? And I got a little bit of guns over there. It's at least a 22. But my left arm is still weaker than my right arm. And that happens quite frequently in the case when you have an injury. Most of us have a weaker side, right? Most of us, the dominant side is our strong side. The non-dominant is the weaker. For me now, it's the exact opposite. My dominant side is my left side, and now my right side is my strong side. So talking about some key terms here: adhesions, collagen, contracture, creep phenomenon we mentioned. We talked about deformation and Golgi tendon organs, load, muscle spindles, remodeling, strain, stress, and viscoelasticity. All these terms we've already kind of covered in Therex, but they're going to come up today again. So what is goniometry? Well, goniometry is the measurement of angles that are created by joints and bones of the body. Places the part of the measuring instrument, the goniometer, along the bones, immediately proximal and distal to the joint being evaluated. It's an important part of a comprehensive evaluation and surrounding soft tissue, and it measures and documents the amount of active and passive range of motion. And if you remember back, I said primarily when we're doing goniometry, we're going to measure the active range of motion. The only real time that we truly take a passive range of motion is if the patient can't perform active. So if the patient has the inability to do active range of motion, we may take a passive range of motion of that patient just so that we get some range of motion measurements. Oh, no, too fast. So the process of measuring and recording available movement in any joint given the various conditions, we may measure passive movement, we may measure active movement, we often measure functional. For standardization, we use a 0 to 180 scale. There's no muscle that goes beyond 180. And I have had in the past where students like, but my shoulder does a full circle. Well, no, because that's like a combination of motions, right? That's when you go down to abduction and kind of retraction, all that fun stuff. The shoulder still only goes 180 degrees max. And in reality, so I'm trying to think, I'm pretty sure, I don't think of any other joint that does it. The shoulder joint's the only one that ever hits that 180. The shoulder joint should hit that 180 in both shoulder flexion and shoulder abduction. But most of us, when we do the measurements, are going to be short on either abduction or shoulder flexion just because we've got tight muscles. There is some disagreement in practice about recording hyperextension and lag, which we talked about briefly, when the subject can't achieve full extension range of motion. Clinics vary in documentation process. So I'm going to show you the way we're going to do it here in the Wnl and Wfl SoCal clinic, because it's up to RPTs on how we measure here. But if you go to your clinic and they use a different technique for measuring, well, then you use that technique. It just is one of those where you start adapting to the way your clinic works. So I'm going to look at the shoulder here because this is a great example here. So we're looking at shoulder flexion here. Right, so shoulder flexion. In this case, the patient has 4 degrees of extension and 135 degrees of flexion. What this 0 indicates is they're able to actually achieve 0 or dead down to their side, right? So usually some clinics will measure that for 0, 135. So that's saying they have 4 degrees of extension, 0 meaning they can go to 0, and then 135 degrees shoulder flexion. If your clinic measures that way, that's okay. The other thing you may see is that a patient has 0 to 4 degrees of shoulder extension and then 0 to 150 degrees of flexion. I would prefer when you're documenting that if you're going to document, so you're going shoulder, so you're here, let's erase that flexion real quick. That when you're documenting on notes from me, that you indicate shoulder flexion, and you indicate the 0 to 150. And then you indicate shoulder extension, and you indicate 0 to 4 degrees. Most clinics will prefer you to separate these out. There's a couple reasons for that. Main reason for this is because you're going to be doing an electronic documentation system for most parts, and it separates them out. Excuse me. The other reason is because if you're not doing a system that separates it out, it gives you another data point to put in that objective. And a lot of clinics really like those data points hitting that objective, so it makes the objective look a little bit bigger, less chance of Medicare auditing us. So in the case of down here, this is the problem. I've seen sometimes where somebody will put this 0, 6, 125. Does that make any sense at all? Like, if you had to read that, would you have an idea of what they're talking about there? Right, to them, and the only reason I say this is because I saw this in the clinic once. What this in the clinic once said was, this is neutral, this is extension, and this is flexion. But that means nothing to me. That's way too, no, don't write like that, please. Unless your clinic does that, don't do that. That's bad. No, stop that. Bad writer. Now, what if I wrote it like this? What would that tell you? If I wrote it like that? Does anyone have an idea? So 6 to 125. I think we briefly touched on this. Yeah, it starts at 6, right? So somebody is saying 6 degrees of extension. Okay. But in order for it to be there, there's got to be a 0 between it for going an extension. So what this 6 to 125 is literally indicating is the patient doesn't reach 0. They're stuck in 6 degrees of flexion. They can never get back to 0. It's pretty much any joint, Mark, actually, the way it should be done. That's why I'm trying to talk about this a little bit. Almost every joint should start at 0. I can't think, well, we'll talk about the ankle. The ankle still starts at 0, even though on our goniometers we'll start at 90. But we should start at 0. If the patient can't, so your ranges should be like 0 to 45, 0 to 60, 0 to 15, whatever it is. If that first number isn't 0, and maybe say that it's 15 to 60, what that should indicate with that 15 is that you have 15 degrees of what's called extension lag. And what extension lag means is you're not able to get all the way back to 0. So you're not able to achieve that 0. Or you have flexion lag if we're talking about extension. So if this was shoulder flexion here or shoulder extension here, this would be a really weird case. I've never seen it. The patient's stuck back here in 15 degrees of shoulder extension, but can go to 60, but they can't get back to 0. That'd be a weird case. I've never seen that. But what it indicates is where they start at, or it should indicate where they start at. So in this case, whatever joint, let's just say this is the knee, and we're talking about knee flexion. What this indicates is the patient is stuck in 6 degrees of flexion. Could be inflammation, could be a frozen joint. They could have had surgery. Who knows what causes it? But they're stuck and they can't get back to 0. And one of the things we're going to talk about in this class and in Therex is extension, 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 extension. What do I mean by that? It's easier to get back flexion on a patient than it is to get extension back. So if you've got a patient that maybe had shoulder surgery and they're fresh out of shoulder surgery and they're limited in shoulder extension, so they can't get back to 0, they can't even get past 0. You know, so they're stuck at 15 degrees of shoulder extension or something like that. We need to work that extension pretty aggressively. The flexion we can get back years down the road, but for some reason with our bodies, once we lose extension, it doesn't like to come back. The knee is a great example of that. When a patient has had a total knee replacement or a partial knee replacement or an ACL tear or whatever it may be, a lot of times the resting position to avoid pain is a little bit of flexion. And then once everything starts contracting up, getting that extension back is really, really difficult. So it's important that as clinicians, we really focus on that extension. It's usually uncomfortable to patients. They don't like going into extension. But we need to stress to them that if they lose extension, it's really, really hard to get it back. Think of all the little old ladies and little old men you see walking around town or walking down on the strip or going down to the, pull the one-arm bandit at the casinos. Their posture is usually very kyphotic, right? They're kind of curled up like this and walking with their walker. That kyphotic posture, right? When they lose that, they're starting to go into a flex posture. They're almost returning to kind of that infant posture where you're in fetal position. The more time they spend in that kyphotic posture, the harder it is to get them to stand upright and get really good posture. So it's important that we really hit extension with our patients. I can't stress this enough. Most docs will be really aggressive. Extension lag is just what it's. So either way, either flexion or extension lag, depending upon what we're talking about, Mark. So an extension lag would be where the patient can't reach zero. So like in the case of a knee, right? So here's my foot, here's my tibia, right? It comes up, and my knee's like that. That would be extension lag because my knee is not at zero. The only place that you would ever really have a flexion lag would be maybe the wrist. But even then, I can't think of a time that we'd use the term flexion lag. We just have a lack of wrist flexion. But we do have extension lag where the knee or the shoulder or the elbow or the wrist or the fingers won't fully extend. For example, my fingers, right? From years of the martial arts, no matter how hard I try, I can't get, I don't know if you can see that from the side, but I can't get them fully extended, right? Oh, I got my middle finger almost fully extended. My ring finger is not, or my index finger is not going there. My ring finger and my pinkies are definitely not going there, right? I've got what's almost called a pseudo-boutonniere's contracture. We'll talk about that later with the hand, but the left hand's a little better. Left hand's because it's also weaker. I can't really get a full extension, especially like here. If I try, I can get full extension if I push it, but actively it just sinks back into an extension lag position. That's what that extension lag kind of looks like. And again, the main area we're going to talk about extension lag is either the shoulder or the knee. Elbows sometimes, but pretty rare. All right, so out of all the hardest topics in this class, this is probably the hardest topic to grasp. So we're going to spend a little bit of time here, because we're going to talk about capsular versus non-capsular patterns. So a capsular pattern is a joint-specific pattern of restriction of passive movements. I don't know why that extra period is there. It indicates the existence of a contracture of the joint capsule itself. There will be a presence of a very typical pattern if the capsule of the joint is affected. Each joint has a very characteristic pattern of limitation. So what could cause the capsular pattern? OA, osteoarthritis, spondylosis, stenosis, spondylolisthesis, rheumatoid arthritis, traumatic arthritis, whiplash, ankylosing spondylitis. We'll talk about all those this semester, so don't worry if you don't know all of them yet. Capsular patterns are based on clinical findings rather than research. And here's why I talk about this. Because some clinicians say capsular patterns don't exist. There are some clinicians that don't believe in capsular patterns. I'll say in all my years of treating, I believe in them and I've seen them. And we're going to talk about why it's important here in a second. So that's a capsular pattern. And the main reason is capsular patterns may be different or inconsistent, and they're not the same for every joint. So in order to understand if you have a capsular pattern or not, you have to know what joint you're talking about and what a normal capsular pattern looks for that joint. A non-capsular pattern is a joint limitation that exists but isn't capsular in nature. Well, that kind of makes sense. If it's non-capsular, it wouldn't present as capsular. Well, what could cause it? Subacromial bursitis, disc lesions, facet, thoracic outlet syndrome, all kinds of normal things. Your typical limitations at that point occur in single motions versus a group of motions. I'm going to explain this in a second, so don't totally freak out yet. The limitations you feel will not follow any pattern is caused by structures other than the joint capsule. For example, ankle dorsiflexion when you're in long sitting. So if I have my legs straight out, I got to hook up my other camera while I'm on break. So if I've got my legs straight out, right? There you can see my foot. Okay. If I have my legs straight out like this, and I try to dorsiflex my foot, I'm limited in how much dorsiflexion I have. Right? Why am I limited? Well, because I have a couple two joint muscles like the gastroc and the plantaris and stuff like that that are limiting my dorsiflexion, limiting me pulling up. That is a non-capsular pattern. Typically, non-capsular patterns are either muscular or just range of motion based in general. A capsular pattern is a series of motions where parts of your motion are limited based upon different motions in general. So it's going to be a whole series of motions that are limited. Non-capsular patterns are typically either one or two ranges of motion that are limited. Now you're going to ask, why is this important? Well, if we have a capsular pattern, does anyone know what the treatment for a capsular pattern is, typically? Because the treatments are a little different. So for a capsular pattern, it's joint mobs. So that's where the PT's got to come in and do joint mobilizations on that patient. For a non-capsular pattern, it's range of motion and stretching. What the research shows is if the patient is not presenting in a capsular pattern, joint mobs probably are not going to help them. They're not going to get them all that much better. Now, does that mean that there aren't those weird cases where a patient gets a joint mob when they have a non-capsular pattern and it makes them better? No, I mean, there are weird cases like that. But for the most part, if the patient has a capsular pattern, the treatment is going to be a joint mobilization. If they have a non-capsular pattern, it's going to be range of motion and stretching. I'm going to beat that into you hopefully by the end of this session, because that is a lot of, or not a lot, but it's a few of your board questions. So your board question may present this patient that has a specific range of motion difficulty. And you are expected to know the capsular patterns of each joint. Kind of, yes, Stephanie. We're going to talk about that in a second, and I'll hit you in a second, Mark. Give me 1 second. So you're expected to know that there is research on the capsular patterns. There is research out there. It's not as solid as research for range of motion and stuff like that. There's not as much research because some clinicians, again, don't believe in it. But a capsular pattern kind of indicates a treatment method. So if we see, oh, wait, okay, so this patient's limited in abduction, external rotation, and flexion, which I believe is a shoulder pattern. So abduction, external rotation, and internal. That's actually internal, external, and flexion. So they're limited in that specific kind of grouping of the shoulder. Then we have a good idea that they have a capsular issue. And at that point, they need joint mobilizations. And the joint mobilizations are going to be based upon what pattern is presented. And we're going to go through that with each joint. Because you may not be able to do joint mobilizations, but you are expected to understand them. And then if the patient just has something like just shoulder flexion limitation, well, then joint mobilizations probably aren't going to help them. And at that point, it is a range of motion and stretching issue. So Stephanie asked, did this help determine what we'll do versus PT? It could, yeah. But also remember, Stephanie, I did say that although the APTA says PTAs don't do joint mobs, a lot of our clinics do expect us as PTAs to be able to at least do what we're going to call joint grade 1 and grade 2 joint mobilizations. I am going to teach you all the way up to grade 5s, not performing them, but make you understand how they work. But in the clinic, we typically are going to talk about grade 1 versus grade 2 joint mobilizations. And I'll talk about that in just a second. So Mark asked, what do we do with capsular pattern patients if clinicians don't believe in them? At that point, we treat what the PT says. Unfortunately, Mark. I've had very few PTs that have stated that joint mobilizations don't work. But what's funny is, Mark, when I've run into those clinicians that say there are no such thing as joint mobilization, or not joint mobilization, capsular patterns, they're just doing joint mobs on every patient. So although they may say there's no such thing as capsular pattern, they're just doing joint mobs on everybody. And so it doesn't, a joint mob will not hurt this patient down here, okay? It won't hurt them. It won't have any negative effect. But more than likely, it probably won't help them either. But up here, for sure. So it's one of those where, you know, you want to call it a tomato and I'll call it a tomato, whatever, it works. And Alec asked, do capsular patterns or restrictions in movement? Yes, typically specific groupings of restrictions, Alec. Yeah, so they just blanket everything with joint mobs. Yep, and then, or they may do range of motion and stretching too. Mark, for example, when I don't do joint mobilization, when I've had a clinician that expected me to do joint mobilizations, we typically are going to do the joint mobilizations first and then add range of motion and stretching on top of it. Because these patients up here will still benefit from range of motion and stretching. But if we don't free that capsule up, we're going to be limited on range of motion. So let's talk what I mean by a capsule. I'm going to clear this here real quick. So let's look at the shoulder. So let me draw a shoulder here. So let's see how bad I meant this. So here's my glenohumeral cup, right? Here's my humeral head. There's my humerus, right? And so this is on my scapula, which is back here. And then here comes my clavicle. That's a really fat clavicle. So what does it mean if it's a joint capsule limitation? Well, remember, with your muscles, right? You have muscles on that shoulder that are coming all over, coming from the back and attached to the back over here. And those muscles kind of form a webbing over the head of the, I'm using the shoulder as an example, but it's a good example, over the head of that humerus. That kind of cup that's holding that head in place is your joint capsule. So that's everything, the ligaments, the tendons, the bones, everything that kind of hold that in place is your joint capsule. That may not be that the muscle itself is tight, but maybe specifically your supraspinatus tendon is tight, or your infraspinatus tendon is tight once it attaches onto the head, and maybe it's binding down on the backside of the humerus. That would be a joint capsule problem. Versus I have a tight supraspinatus or a tight upper trap. That would be a musculoskeletal problem. So when the capsule, and you know, when we talk about it, even when we go further down, right? So here's the elbow, and here's the radius, here's the ulna, right? We have all these muscles coming down and crossing over that elbow joint. That capsule is all those structures that are making the stability of that joint up. The muscles are what's moving it. So even though we talk about the capsule being a kind of independent thing, it's still part of your muscles and stuff like that as well. It's just the kind of part that's not muscly. It's all those tendons, ligaments, and connective tissue-y type stuff. So I'm going to hit joint mobilizations a little bit harder later this semester, but I'm going to talk about the grades really briefly. And you don't have to necessarily get totally freaked out about this right now. We have a whole lesson on joint mobilizations. So don't totally freak out right now, okay? So I can see Stephanie right now going, I've got to write all this down. We've got a whole lesson on it, Stephanie. Don't worry. So Alec, typically, good question. So Alec asks, this only applies to passive movement, or is it active movement as well? Typically, what we'll find if a patient has a capsular pattern is they're limited in active movement, but we can move them passively through the movement, typically. So, you know, we'll say if the patient's got some limitations, like again, the shoulders, flexion, abduction, and internal external rotation. So the patient's like, I can't reach behind my back, right? They're trying to reach, they just can't get that internal rotation to reach back there. And we have them actively do internal rotation. They've only got like 15 degrees. But then we do internal rotation and we're able to get more because they're relaxed. Typically, that's a good example of what a capsular pattern is going to look like. At that point, it's not necessarily the muscle that's limiting them. It's something in the joint itself that's limiting them. Does that make sense? All right. So let's hit really briefly on joint mobilizations here. And I normally have my pillow for this. Where's my pillow at? There it is. So I use my pillow as an example here. And we're going to do this when we actually practice these. So I break these up into two different groups. So grade 1 and grade 2s are for pain and swelling. And grade 3s and grade 4s are for range of motion. So if you had to guess or hazard a guess here, what phase of healing would you do grade 1 and grade 2s in? In mobilizations, what phase of healing? Yeah, the acute phase. Good. Good job, Josh. Right, in that acute phase. This is where we start getting either subacute to that kind of rehabilitation phase, right? But in that acute phase, when we don't want to get a lot of range of motion, we're going to do grade 1 and grade 2s. So if I'm going to range of motion a joint, and again, we're going to go through this, this is not that you have to know all of this right now, but I just want to kind of, this so that you can get this in your head. If this is my joint, and again, if I'm range of motion, if I'm doing joint mobilization, I'm going to put the shoulder in whatever the open pack position is, the elbow, the wrist, whatever it is. And the first thing I have to determine is how much joint play do I have in that joint? So if I'm doing a superior to inferior mob on the shoulder, and I'm pushing down on the shoulder, I'm going to come in and push down on that humeral head and see what my total range of motion is on that shoulder. So on my pillow here, what I like to demonstrate is, first thing I do is I see how much play I have. So I'm going to push all the way down until I encounter tissue resistance. All right, that tells me how much range of motion I have, and then I watch for the joint rebound. Most joints should come back to normal after you kind of give them a little bit of a push. So now I know how much range of motion I have. The next thing I need to know is, well, what am I doing? A grade 1, it happens at the beginning of the range of motion. That's a less than sign. It is an oscillation. What does an oscillation mean? This is not an ocelot, that's a cat. Not oscillation. Good guess, though. Yeah, it's a bouncing, right? So at grade 1, what I'm going to do, I'm going to tilt up a little bit here. At grade 1, remember I said I'm going to find out how far I've got. Okay, there's my tissue resistance. I'll let my tissue rebound. And then at grade 1, I'm just going to literally go to about that 25% mark, and I'm just going to bounce. So all I'm doing is kind of just a general kind of back and forth motion on that joint. What that's doing is kind of causing a little bit of that cavitation like we would normally get from an ultrasound. You're basically just squeezing it like a sponge. Exactly. It is a little bit of a ballistic, remember, Mark, though. It's not, I guess it is technically a stretch of the joint capsule, but we're not stretching a muscle at that point. Right? We're kind of just moving that joint capsule around. Right? So we're just kind of getting on there and just kind of bouncing. Right? Bounce with me. 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 That's a grade 1. A grade 2 has greater range of motion and goes from about 0% to about 50% of the range of motion. So some will say that a grade 2 goes all the way up to 100%. It just depends upon what your clinician does. Okay. So again, I'm going to come here. I find my tissue resistance. I come off. And now I'm going into it and back, into it and back, into it and back. And remember, with range of motion, it's in and back, in and back, in and back, in and back. But typically, again, by the book, you're stopping at 50%. I know this says that some clinicians say 100%. By the book, you're stopping at 50%. And again, we'll hit these later. Don't totally freak out yet. Grade 3s, on the other hand, now we go by the book 50% to 100%. So now, instead of starting way back here at the very beginning, I'm going to start at the 50% mark and go to the 100%, to that tissue resistance. Note, I'm not going into the tissue resistance. I'm not getting a full-on stretch of that tissue. I'm going till I hit resistance and bouncing off that resistance. So at 50% of the way, down to that tissue resistance. And then grade 4, I'm back to oscillation again. But now I'm going greater than 100%. So now I'm going to go all the way down to that tissue resistance, and then I'm oscillating into that tissue resistance. So now I'm getting a little bit of almost a snap, crackle, and pop going on in there. Now I'm not popping the joint. We'll talk about that in grade 5. I'm just getting down to where I push in all the way down to that tissue resistance. I hold at that tissue resistance, and I oscillate into it. That is going to increase the capsular length. And then at grade 5 is also known either as a snap adjustment or a manipulation when you're talking about chiropractic, or in physical therapy, it's a thrust mob. We cannot in physical therapy use this term manipulation because manipulation is held by the chiropractic board. It seems kind of silly. But the chiropractic board says we cannot say we perform manipulations, just like they will not say they perform joint mobilizations. That's our kind of agreed upon, I guess boundaries would be a good term for it. So we typically call them thrust or snap mobs. And you guys may have seen a PT do this before, but the easiest example I can give of that is that. There. I just did a grade 5 mobilization of my MCP joint. A grade 5 mobilization is going to cause that popping and snapping sound. Now, there are people that believe both sides, whether it's a good thing to do grade 5 mobs or not a good thing to do grade 5 mobs. I'm of the belief that it does help certain patients, so I'm okay with that. Yeah, we thrust backs, we don't crack them. Exactly, Mark. You're exactly right. Well, technically, we don't do either, but PTs would do that. Because grade 5s, if you get a question on your boards about grade 5 mobs, and again, we will hit these harder when we actually do the mobilizations. On your boards, if you get a question about grade 5 mobilizations, those are a hard no. We do not do them. And I'm going to be 100% honest with the things that can happen in the spine if we're doing spinal mobilizations like that. I'm actually okay with that. Because it's not that hard if a patient already has a slipped disc. If you do a joint mobilization, do a thrust or a snap mobilization, to possibly tear part of that disc. So I'd rather leave that to the professionals and let the PTs do it. I'm okay with that. I'm okay just doing grade 1s and grade 2s. I have in some clinics done grade 3s and grade 4s. And we'll talk about that like in certain states. So the APTA says that technically PTAs can't do this at all, but they leave it up to the states to decide. And in certain states, what they'll say is, well, PTs can't do mobilizations, but we can do, what do we call it in Pennsylvania? Glides. There we go. We can do joint glides. They're the same thing. The only difference is we didn't document what we felt in our assessment. Whereas when a PT does a graded mobilization, they will put in the, yeah, I'm going to talk about that in a second, Mark. Great question. So I'll answer that in a second. You know, when it comes to these mobilizations, it depends on what your state's rules are. So that's going to be important. So Nevada right now, there are no rules on mobilizations. It's something we have to look into. And I brought this up at the last meeting that we really should get we really should have a law on this so that we have something on the books about it, even if it's just saying it's okay for PTAs to do joint mobilizations. At least that way we have something on record. Like I said, in Pennsylvania, what they said was PTAs can't do joint mobs, but we can do joint glides up to a grade 4. And so we would document not that we did joint mobs, but that we did joint glides, and then the grade of the joint glide. What the APTA says about joint mobilizations is that it requires the consistent and constant evaluative capacity of a PT. So what that's saying is that every time a PT is doing a joint mob, they're constantly assessing that joint. So no matter what your state's rules, it's all in the verbiage, you're 100%, Mark. No matter what your state's rules are about joint mobilizations, I will say this, we don't document anything about them in the assessment portion 100%. Does that make sense, everybody? Like, we will not talk about them at all in the assessment. Doesn't matter if the patient had pain during the joint mobilizations, or, you felt more range of motion with the joint mobilizations today. We just do not talk about them in the assessment at all, period, as a PTA. Does that make sense so far for documentation? Well, no, I'm talking about the assessment portion first, Mark. So in the assessment portion, when we document what we find as a PTA, we're not going to put anything that we find about that joint mobilization in the assessment. In the objective, if joint mobilizations are performed and our state allows it, we are okay to document that we did 2x30 grade 1 joint mobilizations anterior to posterior on the shoulder. So we can document exactly what was done as long as it's okay by the state law. If you're in a state, for example, I'm going to use Delaware as an example, because again, I'm used to the East Coast. West Coast is still kind of Wild West, like Mark said. In Delaware, if I had joint mobilizations on a patient, I had to have the PT perform them. I would still document in my notes that the PT, I would say, grade 1 joint mobilizations performed anterior to posterior on patient shoulder, performed by, and I would indicate what PT did them. I'm still documenting that they were done, but I'm also putting in that note that I didn't do them. Does that make sense? That's kind of the weird way of doing it. And again, we will hit this harder when we get into joint mobs themselves. And once you guys kind of feel what a joint mob feels like. Did I burn anyone out with this? You understand what I'm talking about? We're going to go back to Capsule. Yes and no. Okay, good. So why did I kind of go through this spiel about joint mobilizations? Well, because that relates back to capsular and non-capsular patterns. So if you have a capsular pattern and you get a question on that on your boards, it is acceptable to say that the patient needs joint mobilizations. It is okay to say that joint mobilization will be a valid treatment. It's not going to say you perform. It's just going to say that joint mobilizations are indicated or contraindicated, right? Although even in non-capsular patterns, joint mobilizations aren't contraindicated. What do you think might be a contraindication for a joint mobilization? What do you think might be a contraindication for joint mobs? What are some of your blood clot in the area? Good, Mark. Yeah, right. Malignancy. Good. Those are your two ones. What's your third one that you can always fall back on? What type of fracture? Well, pregnancy, maybe. Okay, good. Actually, Josh, that's actually really good. That's a good point. I'll hit that in a second. What's that big one with a fracture you can always fall back on? What type of fracture? Unstable. Yeah, unstable is your big one, right? And if it's an open fracture, Stephanie, it's an unstable fracture. Yeah, unstable is your kind of gold word there. Unstable means it hasn't been assessed by a doctor, right? And it hasn't been put in place or whatever it may be. That's okay. That's why we hit this. It's a learning process. I'm trying to train your brain a little bit, right? Unstable fracture is that, so usually, for the most part, almost all of your modalities, treatments, whatever, malignancy in the localized area, blood clot in the localized area, unstable fractures are your three fallbacks, and then pregnancy is a good kind of fourth fallback. And with pregnancy, the reason we're going to watch that with joint mobs is because of the relaxin chemical, right? That chemical that causes the woman's muscles and ligaments to become very lax, because it's not going to be that hard to tear. So the main thing I want you to get out of this lesson, you don't necessarily have to get all this yet. We will hit all this down here in a little bit in the lesson on joint mobs. But the one thing I want you to get out of this lesson is if you have a capsular pattern, joint mobs are indicated. If you have a non-capsular pattern, range of motion and stretching. That's an M. You at least get that part of it for now. Is that part at least clear? Even if you don't understand fully what a capsular pattern is, because I think I've got the capsular patterns coming up. You at least get that part of it. Okay, good. All right, that's what I'm looking for, is at least that we get that part of it. The rest of it will come, young Padawans. So when we get a joint, and I think I put all of these joints in here for you, I would highly recommend these 3 slides, taking and printing them out on individual sheets and putting these in that clinical binder of yours. We're going to go through each of these joints as we go through the body. Well, that really kind of makes me look weird, doesn't it? But what this is saying is this gives us our blocked position. What do you think blocked position is another term for? What's that other position called? For when the joint is most congruent. Closed packed, good. Right? This is our closed packed position. That means relaxed is our open pack. And then over here we have, what does a capsular pattern look like for that joint? So I hope this makes you a little bit enthusiastic that when you start studying this, I have already made a nice little chart for you. Right? So block position is closed, relaxed is open. Remember that this position is the post position of stabilization. This is the position of mobilization. And this is what it'll look like if you have a capsular pattern of that joint. So let's look at the hip just briefly. So the hip says the blocked position, or the maximum contact position, where that joint is as congruent and as tight as it could possibly be, is max extension, so the leg back, internal rotation, and slight abduction. Why is that? So if this is my hip joint, right? I'm going to try to get my leg down. So there's my hip joint. It's saying slight extension. That's going to rotate my head into that socket. Internal rotation, right? And slight abduction. It's locking that hip, that head of that femur into that socket. That head is in there and it's not going anywhere. That is the closed packed position. And then open pack for the hip, we come back to neutral. It's slight flexion, slight abduction, and slight external rotation. So about 30, 30, 30 is usually what they say for that. In that position, that's the position we can mobilize the hip. Why would we do mobilization? If the patient has limits in flexion, internal rotation, and abduction. So if they're limited in all three of those, that's an indication that it is a capsular pattern, and therefore we should do joint mobilizations. If they're just limited just on flexion, that's the only thing they have the problem with. That's not likely a capsular. So Mark says, is it fair to say when anatomical position, everything's in close back? It's pretty close, Mark. Except for like the wrist, because the wrist is in open packed in anatomical position, because the wrist is in neutral, right? So there are some joints, elbow, yeah, elbow would be closed packed. Shoulders, not fully closed packed in that position, but it's getting closer. So it just depends. That's not a hard rule, but it would be a safe rule to maybe if you're looking for something, Mark. Like you're like, I can't remember. Getting in the anatomical position probably gets you pretty close. Yeah. So back to what I was saying is, if you have a patient that just has flexion problems, that probably isn't a capsular pattern. Now I say probably because it's pretty rare, but it may be a capsular pattern. And we'll only find that out if we're doing exercises with them and stretching and strengthening and we don't get anywhere. But if you have a patient that comes in and they have flexion, they're limited in flexion, they're limited in internal rotation, and limited in abduction, more than likely that is a capsular pattern, and we want to do some joint mobs on them to kind of break up any of those adhesions in that joint, or kind of loosen up and stretch out those ligaments so that we can then get to stretching and strengthening. So like the knee here, right? Max extension, and the knee does have a little bit of rotation in it. External rotation is kind of where it goes into when it goes into that locked position. At that point, the knee is in closed packed. Open packed is about 25 degrees of flexion, so kind of relaxed position, kind of like what you sit in when you're sitting there with your leg down from your chair. If the knee is limited in both flexion and extension, that is likely a capsular pattern. If the patient is only limited in flexion or only limited in extension, that is unlikely to be a capsular pattern. So the next thing I'm going to hear is, Mr. McKeever, do I have to know all these? Because I'm pretty sure that's going through somebody's mind in here. And this is where Mr. McKeever makes you kind of sad and says yes. Because this is and I try to make this as simple as I possibly could for you when I designed this chart, to kind of just go down through and get almost every joint we could possibly have. Because I've got all the way down, look at this, I mean, I've got down metatarsals. and phalangeals, right? I've got my glenohumeral, which is your shoulder joint. I got sternoclavicular, acromioclavicular. And I kind of went through all the joints you possibly could hit and made a nice little chart for you guys that if you take this to the clinic. So Josh asked, capsular pattern is an issue with the joint and non-capsular? Yes. Typically, yes, Josh. So capsular is an issue of the joint itself, whereas non-capsular could be manual, could be muscle related, could be musculoskeletal, could be at that point where it's just not related necessarily to the capsule itself. I know it's a both, right? Let me make things a little bit better for you, because that way I can make you guys feel a little bit better, okay? If I am one of those people that I absolutely need to study stuff, right? And I can't study this much. You definitely need to know the hip. You definitely need to know the knee. The talocrural and the subtalar are also two joints that are kind of important. That's the ankle joint, right? Tibiofibular, maybe if you're dealing with athletes, but not so much the average Joe person. Okay, so that one I'm not too worried about you knowing. I put it on there so that it's there for you. And the feet, the only time you really have to know those is if you're working in a clinic that specifically deals a lot with foot injuries. So I put them on there in case maybe you're going to a sports clinic and that clinic deals with a lot of plantar fasciitis, a lot of foot injuries. Well, now you've got them at least if you need them. So out of that, you know, maybe 3, maybe 4 of those you need to know on that list there. When we come over here, glenohumeral is important. And then we get down here, these two, humeral ulnar, radiohumeral, are important. That would be the elbow joint. And then the wrist joint. The rest of these, so this group, and this group are more important if you're working in a clinic that deals specifically with those joints, particularly like in this case, it'd be an upper extremity clinic, like a hand therapy clinic or something like that. You know, for example, my wife has to know all of these because she works specifically in a hand therapy clinic where the only thing she deals with is the upper extremity, right? So she better know these inside and out. And I pick on her sometimes when she doesn't, because that's me. And then she's like, do you know them? And I'm like, yeah, hold on. The radial ulnar joint is. So that's why I kind of designed this chart. So if I'm a person that's studying for your boards, the ones that I just indicated are the ones that are really important for your boards. Does that make sense? I put them all on here so that you're not short if you go out to the clinic and, you know, Mark's out in the clinic and his CI goes, what's the closed pack position for the distal radial ulnar joint? And Mark goes, man, I know Mr. McKeever talked about it, but I don't remember it off the top of my head. I will find out and I'll get back to you. He can go back to his book. Right, that's it. You can go back to your book and say, okay, so it's about 5 degrees of supination. Right? And you can get that the same day if you have this in your chart rather than having to come back the next day after researching it, right? Does that make sense? That's why I gave you all of them. But the big ones are the joints you want to know. So your shoulder, your elbow, your wrist, your hip, your knee, your ankle. Does that make sense? Yeah, I want to make sure that you have everything, but at the same time, I want to talk about the ones that are important. Because that's really what, 9 times out of 10, that's what everyone says is, I only care about the ones that are important, Mr. McKeever. And that's when I go, well, they're all important, but these are the most important. So just to review this again, right? I should have put the top there. I'm sorry, I should have just included that on everyone, but I think I just made this one sheet and I didn't bring that down. If we need to, yes, Stephanie, go ahead, before I ask my questions.
Okay, the capsular pattern, they have to demonstrate all 3 to be a capsular pattern, to be a joint mobilization. Otherwise, if it's only one, then it's usually range of motion and stretching. So it's not. Yep,
typically. Now, you know, you've got somebody that's got, like, say, the hip here, and they've got flexion and internal rotation, but they don't have an abduction limitation. that's one where we go, well, let's try stretching and range of motion first and see if it improves. And if not, we may drop back to a joint mobilization. Does that make sense?
Yeah.
Okay, cool. Yeah, so typically, if the joint presents with all of these, yes, that is a capsular pattern 99.9% of the time. And then we would do joint mobilization. That was actually going to go where my question is next, Stephanie. So if we are putting a patient in a position of stabilization in order to protect the joint, what position do we put them into? A position of stabilization to protect the joint. Closed packed, good. If a patient presents with a capsular pattern, then we are going to do what we typically are going to, what is indicated for them at that point? If they present, yeah, joint mobilizations, good, right? And that means we are going to put them into what position? Open packed, good. Do you see how those tie together? So let's say you have a patient like Stephanie's talking here with this hip patient, and the patient's got flexion, internal rotation, and abduction. Well, then you can go right back to your chart and go, oh, well, this is about the open packed position. I'm going to put them in that position, and then my PT can do some joint mobs. Or I can do some joint mobs if your PT's trained you on them. I will teach you some basic joint mobs. Huzzah! Because one of the big ones that our PT clinics expect you to know is patellar mobs. So moving around the patella. That's probably the biggest one that most clinics expect you to know. And then second would probably be the shoulder. So we'll cover both of those in the joint mobilization class, and we'll actually get to do them. And some of you will come out of that class going, man, my shoulder and my knee feel better than they felt in 15 years. Because you might have had a little bit of a capsular pattern and not known it. And so you're like, oh, that feels good. They might, yeah. So Josh asked if a patient has a capsular pattern, they have an issue getting to open pack. They may. That's a great question, Josh. And in that case, we just get them as close to open packed as we can get them. Or at least get them out of closed packed. Right, so start them somewhere and then hopefully get them to where we can go into full open pack. Does that make sense? Because not everyone, I guarantee you, especially with the, when we get down, let me get down to the shoulder here real quick. So with the shoulder, like the glenohumeral joint, abduction 55 degrees, right? Adduction, I think that's supposed to be the actual, or abduction or adduction of 30 degrees, depending on what you're doing, and then internal rotation. A lot of patients limit internal rotation. So you're gonna be like trying to get them there and not gonna be anywhere. What do? I just get them kind of out loosey-goosey out to the side, and that's where I mobilize them. Until I can get them into a more, get them as close to those degrees as you can get. You're exactly right, Stephanie. And if you ask a PT, what are the exact degrees, they're gonna laugh at you. They don't remember the exact degrees, they just kind of remember the motion. I'll be honest, I don't remember the exact degrees until I studied for this class. And then I have here, so this is the last page is kind of, it's not as important as the other pages, but it is still important if you're working in clinic. This talks about everything from the spine, right, up to the temporomandibular joint. And this is where I get somebody that says, but wait a minute, Mr. McKeever, are we going to actually work on the jaw? Yep. And if you are so lucky to have to do joint mobilizations on the jaw, guess where your fingers have to be? In their mouth. Because you've got to get in and get a hold of that mandible. So yeah, it can get fun. So make sure you put gloves on, that's all I'm saying, folks. No, I'll pass. Glove it and make sure that you're not working with a kid. It's not that bad, you're right, because you're not going to move a lot. You're exactly right, because I think you worked in dentistry, right, Stephanie? Yeah. It's honestly, I'll do TMJ joints or mobs all day long because there's not a lot of range of motion in that joint. And literally I can do it with 2 fingers. rather than like somebody's hip joint, man. Like if I'm doing joint moves on Mark's hip, whew, I'm gonna get tired real quick. Just because Mark's got some big old legs like me, and you're gonna wear out. And what we're gonna do is I'm gonna show you some different ways to use belts to help you do joint mobilizations. Because there are techniques we can use using a gait belt that you can then use your body to do the joint mobilization versus your arms. And for some of you, like Stephanie, unfortunately, you're kind of tiny. You start moving around my legs, Stephanie, you're going to get tired quick. I'm just saying, each of my legs is about 100 pounds. It feels like it, at least. Right now, it definitely feels like it. Excuse me. So we'll teach you ways to kind of use your body to the best of its ability. Am I clear as mud on the capsular and the uncapsular pattern? Or non-capsular, at least for now. Again, we're going to hit this the whole semester. So every time we go into a joint, when we start going into the hip, the knee, we're going to go back to this. What is the capsular pattern? What is the non-capsular pattern? And so we're going to beat you. By the time you get to the end of the semester, you're going to be like, Mr. McKeever, I get capsular, I get non-capsular. And the only reason I say that some people don't believe, like Dr. Sokel and I have had a discussion about this. Dr. Sokel really doesn't fully believe in capsular patterns. She agrees that joint mobilizations work. And she's seen joint mobilizations work, but she's still not sold on the idea of capsular patterns. I'm not throwing her under the bus here. She's just one of those PTs that doesn't. And at that point, we just say, okay, we do what the PT says. I'm okay with that. I've worked with PTs to say that capsular patterns aren't a real thing. But they're still having me do joint mobilizations, which is hilarious. Let's stop sharing here because it's about 9:30, just about, because I know that we need some. So we don't know all of them right now. No. As we go through the semester, Alec, we'll pick them up as we go. You're 100% correct. I wanted to put them out there so that you start to see them, right? And start to understand the concept of why they're important. But then as we go through the semester, we're going to keep beating these into you. Right? Let's take a break. I'm going to pause recording. All right, so we are back. I want to make sure I'm still using the right microphone. I am, because for some reason my microphone likes to switch to my other mics. I've got 3 of them. Okay, so we finished last second talking about capsular versus non-capsular patterns. We talked a little bit about open versus closed pack. That goes along with the kinematics of the joint. So the study of motion without regards to the forces, right? Kinematics is just that study of motion. Describes the type, direction, and magnitude of the motion, the location of the bony segment in space, and the rate of change or velocity of the segment. So when we talk about the kinematics of the joint, we're really just talking about the pure motion in the joint, right? We're talking about whether it moves translatory, meaning linear, whether it moves Rotarian or rotary, meaning angular, or a combination. In most joints, again, for the most part, are a combination of both translatory and rotary, right? Because that goes along with that roll, spin, glide rule. So that's talking about the arthrokinematic skin. That refers to the movement of the joint surfaces, slides or glides, spins and rolls. It examines the amount of motion, the tissue and the resistance at the end of the motion, and the effect on symptoms. When we're talking about those arthrokinematics, a lot of times it's really hard to measure the specific joint, joint on joint motion with a goniometer or standard ruler, but it's subjectively compared to the other side. So if we're talking about when we're feeling kind of the actual movement of the humerus in the humeral socket, it's not as easy because we don't have an x-ray to look at how it's moving smoothly within that humeral socket, that arthrokinematic portion. But we can feel it, right? We can feel what it feels like to move through that range of motion and compare that feel to the other side. So that's one of the things we're going to talk about in kinesiology is every time we take a measurement, we have to measure the other side. And why do we have to measure the other side? Because we have to have something to compare it to. So if I'm measuring, the shoulder flexion on my right side and I'm feeling how that joint moves, I've got to measure the shoulder flexion on my left side and feel how that joint moves. you have to have that bold comparison between the two. If you don't have that, we don't know. And then comes the question usually from somebody where we say, well, how often do you measure the other side, Mr. McKeever? And it depends. If I know if I'm working on the patient, their right shoulder is their problem, and I know that their left shoulder is within normal motion, it's within normal limits, it's completely normal, there's no abnormality about it, I don't measure that left shoulder every visit, but I may measure the right shoulder every visit. And then, you know, for the eval or the re-evals for the PT, when I'm providing them with range of motions, I usually then will measure that left shoulder to give something to compare to. So we're going to talk about two things with documentation here that you'll see a lot on their charts. These two abbreviations, WNL and WFL, right? What does WNL mean? Does anyone have an idea? Within normal limits, good, right? So within normal limits, good job. Then what's this WFL mean? Within functional, good. Stephanie's already on it. She's like, I got this one. Good. And I abbreviate functional a lot, FX, because that's the math term for it. So I apologize that if anyone sees that on my abbreviations when I'm writing, I don't put that in the chart. But when I'm writing here, I usually document functional as FX because that's function in math. So what am I meaning about this? Well, let's just look at shoulder flexion, right? So we're going to look at shoulder flexion. Within normal limits means that the joint would go from 0 to 180 degrees in shoulder flexion. That's from here all the way up to here, right? That would be within normal limits. That means that joint has its full normal range of motion. Within functional limits can be a bit subjective because there's a couple different functions. But if the patient has, 0 to 100 degrees, for most activities, that patient is within functional limits. 0 to 120, exactly, Steph. So somewhere in that range, 0 to 100, 0 to 120, somewhere in that range. That patient can do most everything with their shoulder. They may not be able to, do a pull-up or something like that, but for the most part, they can do most of their normal life activities. Right? So that's kind of the difference between within normal limits and within functional limits. Within normal limits means they have everything. Within functional means they can do most things. So sometimes we'll talk about both of those. And a lot of times you'll see in the chart, it'll say, let's say that my right side is my affected side. It'll just say left side grossly within normal limits. So if you saw that in the chart, what would be a good assumption there? And let's say shoulder with shoulder, left shoulder, grossly within normal limits. What would that tell you? Yeah, for the most part, they have full range of motion, right? So there's not any glaring, deficits. For the most part, the shoulder is functioning normal. And we don't really have to worry about too much as far as loss of motion. Ideally, we kind of want to make sure that we kind of get patients to this functional motion, if nothing else. I'd love to get them fully back to within normal limits, but at least we need to get the patient to within functional limits. So when we are starting to test for range of motion, right, we're going to put the patient in a position that stabilizes the body and will stabilize the proximal joint segment. Then we're going to isolate the motion to one joint at a time so that it's a true motion or range of motion measurement of that joint itself. And then we may supplement positional stabilization with manual stabilization. So if we see that a patient is cheating for whatever reason, right? So say we're testing shoulder flexion and we see them using their extension of their back to try to get some more range of motion. We may stabilize them manually to keep them from cheating. Yep, that's pretty much it. So Mark says we shoot for functional first and work up to normal. Yep. That's pretty much for the most part the way we go, Mark, unless we know that they're already kind of at functional but not fully at normal, and then we're going to go for normal. Because sometimes patients come to us and they're just like, you know, I can get here, I can do most of my stuff, but I just feel like I'm missing that last bit of range of motion. Well, then we're going to go for normal limits. But at minimum, we want to try to shoot and hit that functional limits at least first. So we want to get them as back to kind of getting everyday stuff done as possible. So what is a priority versus pointless goniometry, right? So why would it be a priority to palpate? Well, palpation is a standard examination technique, right? Palpation is when we get on a patient and touch them. Helps us assess muscle spasms, skeletal alignment, and any myofascial restrictions. We can really feel those things when we are physically touching them and moving them through the range of motions. Can help us identify shortening or lengthening of muscles in relation to the patient's condition. Helps us identify poor habitual posture, atypical movement patterns. Will help us determine limited range of motion or passive range of motion. And it will help us understand where their muscular pain is, because sometimes patients only have pain in what's called a painful arc, where they'll say, you know, I'm good here, and then my pain starts, and then I get through it, and then I'm okay again. And they just have that little bit of range of motion where they have a painful arc. Palpation can help us determine where that painful arc is and kind of see what we might be able to do to help it. So that's, you know, when we palpate and we perform goniometry, all of these kind of help us, or a standard examination technique. Why might it be pointless to palpate and also do goniometry? Well, if the patient has psychosocial issues, meaning they don't like to be touched, they can't handle being touched, they have some other kind of, you know, dissociative identity disorder or something that's going to prevent us from doing an effective treatment. At that point, it may be kind of pointless to try to even do range of motion and goniometry with them, or even to palpate them, because we don't know what the result's going to be. If they have extreme levels of pain, you know, if this patient is literally just writhing in pain, that's not necessarily the time to do goniometry and range of motion. It's time to determine why they're in so much pain. When we know that muscle length and range of motion is not related to the patient condition. And what do I mean by this? Like, I've had a patient come in where they've got low back pain and they're missing range of motion on their low back. But the problem is they're pregnant. And so muscle length may not be the problem at that point. The problem is, well, baby's sitting inside the uterus and is just messing mom up. At that point, measuring range of motion is kind of pointless, because it's the range of motion is either there or not there, but the baby's going to be there regardless and affect the range of motion. If joint motion is prohibited, if the doc says, do not let the patient go into flexion, don't measure flexion. We're going to talk about this with total hip replacements, right? THRs. And we're going to talk about a couple different types of total hip replacements, but I'm going to talk about the posterior hip right now. So a posterior total hip replacement, or a posterior approach, when the doctor does the surgery, they're going to go through the glute min and glute max. So they're going through the back side, and it's literally going to be kind of right above where their ischial tuberosity is where that scar incision is going to be. When the doctor does this, the patient is not allowed to flex past 90 degrees. And you don't have to know these right now. We're going to go over these in Therex. They're not allowed to adduct past 0. So they're not allowed to cross their legs. and they're not allowed to do internal rotation greater than 0. So not allowed to turn their foot in. So we'll tell this patient, no bending way over, no crossing your legs, no turning your foot in. Well, if we have a patient that has a total hip replacement, we're not going to measure adduction, and we're not going to measure internal rotation because those are contraindicated, right? So let's say we're doing documentation and we have our adduction and we have our internal rotation on our chart for measurements. Does anyone know what abbreviation we put in there if we can't test them? Because you'll see this on the chart a lot. You'll see NT. NT literally means not tested, right? And so if you've got a patient that's got a total hip replacement, we can't do those range of motions with them. We've got to say, okay, we're not going to test those 2 range of motions. We're only going to test whatever we can. And then hip flexion, we're only going to test the 90. So if joint motion is prohibited, we're not going to measure it. That just seems silly. If it's doc says not to do it, we shouldn't do it, even if we're doing it in a physical therapy setting. And in the case of like this total hip replacement here, the reason we don't do these motions is because it can actually cause the total hip to dislocate. And the last thing we want to do is have the patient go back in for more surgery to replace the hip that they just replaced. So if the motion is contraindicated or prohibited, we're not going to do it. If the muscle tendon or the tendon or muscle itself is severely inflamed. So if you've got a patient that has really, really, really bad tendinitis, tendinosis, tenosynovitis, any of those conditions that it's in an acute flare setting and it's really, really inflamed, like you can feel the heat coming off of it, it looks red and angry, and they're just like, man, it just hurts today. Measuring range of motion at that point is pointless because they're going to be limited by their pain. They're going to be limited by that inflammation. So there's no point to palpate that. There's no point to move them through the range of motion. There's no point to measure that on a day where that inflammation is just keeping them from doing anything. Why is it important to kind of take an idea of when it's important to measure and when it's not important to measure? Well, because that saves us. If we know we don't have to do hip range of motions in certain directions, we don't do them. That's one less thing we have to do when we're treating them. But we do have to understand when we do need to measure those. What do we do to measure range of motion and muscle length? Tape measures are used. Manual, universal, and digital goniometers are used. Inclinometers, or what we call bubble gonies, are used. We can use cameras. There are electro goniometers and gyroscopes we can use. Motion analysis system and smartphones are even used now. I've now seen there's a new system, and I'm trying to see if I can talk. I think it's Patterson that has it, or I don't remember which company it is. But this one company has these really cool not electrodes, but they're like electrodiodes. That if I'm measuring elbow flexion, I can put one of the diodes here, one of the diodes at the elbow, and one of the diodes at the wrist. And if I hold my smartphone and have the patient move through the range of motion, it actually measures their range of motion for me and documents it. So there are all kinds of cool new devices coming out. Now, we're not going to use those when we practice. We're actually going to practice with a good old-fashioned goniometer. But there are all kinds of cool new toys out there to help us get a better idea and a more accurate measure of range of motion. Here's kind of our universal goniometers, the most common instrument to measure clinical range of motion in the setting. They're really versatile. They measure most joint positions, range of motion throughout the body. They consider a similar body and 2 arms. It's very similar to a protractor with 2 long arms on it. The alignment arm aligns with the proximal and distal segments of the joints. We'll talk about that. And the cost varies, can be anywhere from $5 to $100. Now, we will give you guys all a goniometer for your first clinical affiliation. So you'll get a goniometer and you'll get a gait belt and what else you get. It is a major price difference, Alec. And mainly When we get down here to kind of these $100 gonies, I don't have one here. I have one in the clinic that's about $100. The main difference between the cheapy gonies and the more expensive goniometers is a lot of the more expensive goniometers have extendable arms or have a digital gauge on them that measure your range of motion that you don't have to kind of take it up for your own. I find that honestly, using these typically like the baseline up here, that's kind of the most common one you'll see. That one's like $15. So it's kind of a very common goniometer and everyone uses them. I probably have a few laying around here somewhere. I'll get one up during break so we can kind of talk about it. But it just varies. I mean, you can get cheap ones on Amazon. You can order a whole bag of cheap ones from like AliExpress and stuff like that as well. Then the gravity-dependent goniometers or inclinometers are little bubble goniometers. I'll pull up a picture of those then. But what they just look like is they kind of look like a regular style protractor. And inside them, they have fluid. And as that fluid moves through the goniometer, it helps us measure the change of inclination. It's basically a level. Yeah, pretty much, Josh. Yeah, it's not that far off. It's just a level that's curved, kind of like the Earth. I had to throw that in there a little bit. Had a fun debate this weekend. I wasn't part of it, but I was doing the moderation for it. I've seen PTs use pendulums. I don't know how to use pendulum for goniometry. I don't understand it. So I won't be teaching you guys how to use those, but we'll do bubble gonies. The main reason we use bubble gonies is on the spine, because it's really hard to measure the spine with just kind of a standard goniometer because the body's big. So it's kind of hard to measure it with a regular goni. The bubble goniometers give us a little bit better of a range of motion, and we can also get like a full back range of motion with a bubble goniometer, getting the whole way from cervical down to the pelvis. So when we're looking at a goni, we're going to talk about this when we measure joints. The important thing to understand is the stationary arm is the one that stays with the goniometer. The other thing you can say is the non-moving. That is the non-moving arm or stationary arm. We then have a fulcrum or a pivot point. That's the part we're going to put over the axis of the joint. And then the moving arm is going to go with the part of the body that is moving, so we can measure the total change in range of motion. I'm going to use the shoulder for an example. So let's draw my shoulder here. So there's my shoulder. There's my elbow. There's my wrist and my hand down here. And there's my hand. Right? So when we are measuring shoulder range of motion, our axis or our fulcrum is going to go right kind of through the center of that shoulder joint. We're going to talk about using the greater tubercle as kind of our fulcrum for that. That means you have to be able to palpate the greater tubercle, right? You do that by putting your hand on that shoulder, have them internally and externally rotate and find that greater tube. There's my greater tube. I found it nice and neat. So we're going to palpate for that kind of fulcrum point or that pivot point of the shoulder. And then we're going to take our goni and we're going to line up that stationary arm with the body. And again, this isn't, I'm not teaching you how to do this yet. I'm just kind of walking through how we might do one. That's going to follow the kind of midline of the thorax. That gives us a baseline to measure off of. And then our movement arm is going to move with the humerus as it moves through its range of motion. Using bony landmarks like the lateral epicondyle and the distal lateral styloid process as kind of guidelines for the end. Because obviously if I put a goni on my arm, it's not going to go all the way down necessarily to my lateral epicondyle, but I'm going to kind of sightline it on that lateral epicondyle of my arm. That's why when we measure range of motions, typically we're going to keep them as close to anatomical position as possible. So that static arm or that stationary arm is always going to line up with the non-moving portion of the joint, or something like a midline of a body. And we'll talk about when we line up with certain things with each joint. That moving arm is always going to go with the kind of, I guess you could almost call it the like the open kinetic chain portion of that joint. So that part that's moving, right? Part of joint that's moving. So let's kind of think through a couple of these. So I talked about the shoulder a little bit. Let's talk, just thinking through logically, if I'm doing shoulder abduction, so coming out to the side like that, give me an idea what you think might be the fulcrum or the pivot point that I'm going to measure off of. What kind of a bony landmark could I use as a pivot point? Okay, the acromion, specifically the acromion what? Process, right? The point. Yeah, good. That stationary arm, the arm that's not going to move, we're going to line it up parallel to the sternum. I wasn't going to ask you that. And then that moving arm is going to go along with the humerus as it moves through the range of motion. And I believe the lineup is with the antecubital fossa. Don't quote me on that off the top of my head, but I'm pretty sure it's with the antecubital fossa. So we're going to move them through and we're going to measure it. Let's talk through a couple more. Let's look at the elbow. So for elbow flexion, we're going to measure at the lateral aspect of the arm. Someone other than Josh, what do you think the fulcrum we're going to use for elbow flexion is going to be? So that point that it's going to pivot around. Good guess. We could use the olecranon. What else could we use? The lateral epicondyle. There we go. Yeah, that gives us a good point that's not really moving very much. The olecranon moves a little bit when we go through. If you feel, like if you put your hand back here, the olecranon kind of shifts out, right? So that lateral epicondyle kind of stays static. And then we're going to line up. What do you think we're going to line the static arm or the non-moving arm of the goniometer with? The non-moving, not the moving. Yeah, the humerus. Good, right? We'll talk about where the final part is, but yeah, we're going to line up with the humerus. And then Mark's right. We're going to line up that distal, that moving arm, with the radius and ulna, so we can get a measurement, right? So let me. I know my goniometers are over here. Oh, there they are. There we go. Right. It's a really bad goniometer. I don't like these loosey-goosey goniometers. Right. So if I'm measuring, I'm going to line that kind of stationary arm up with my humerus. Stand it up a little bit. Line that fulcrum up with my lateral epicondyle, and then I'm going to measure as I move through the joint. And again, this is not perfect right now. We're just kind of doing a little bit of kind of think and tell. Let's go down to the knee. So now we're measuring, let's say we're measuring knee flexion. What do you think we're going to use as the fulcrum again? Because again, remember that most of the time the knees and the elbows follow suit. Yeah, right, the lateral epicondyle of the femur now. And then we're going to measure that stationary arm up with our femur and the movement arm up with our lower leg and move ourselves through knee flexion. When we measure all of these, there are going to be standard positions we put the patient in. I'm going to kind of teach you guys the standard position that the book requires you to learn. And then I'm also going to talk about positions that you'll see commonly in the clinic. Because I know, like, for example, we do shoulder flexion. Shoulder flexion is done in supine. but I know somebody here, typically, Mark, typically we're always going to measure from the lateral side or the anterior surface of the body. Because if we're doing abduction, it's typically anterior surface. But typically we stay lateral. But I know that when I teach you guys how to measure shoulder flexion, somebody in here that's a tech is going to say, but Mr. McKeever, I've seen my PT measure shoulder flexion and seated. And that's not wrong. That's just not by the book. And as long as your PT, when they do that, does their measurements consistently that way, they can get very consistent at it. Right? But if they measure one person in supine and one person in seated, that's not a very consistent measurement. They've got to stay with the same thing. So Josh says, can we let the arm be neutral, or does it have to be in anatomical position for shoulder flexion? So we're not going to put it way out here if that's what you're asking. Josh, we're kind of going to keep it neutral with the thumb. So most time with shoulder flexion and abduction, we're going to have the thumb up. That's probably where you're asking. We're going to do what's called the open can position, right? Where they're holding a can so it doesn't dump out. Yeah, neutral grip. Yep. Because if I keep my let's say I stay in anatomical position, it's a lot harder for me to get full range of motion in shoulder flexion, and it's kind of really hard when an anatomical position works for abduction. Doesn't work if I keep it this way because I kind of bang off that acromion. So we will move the hand around a little bit for rotation when we're doing different motions. Yes, Josh. And we'll talk about that when we go through each of them. And here's some of those the Electro Goniometers. So not really for goniometry, we're not really worried about open or closed pack position, to be 100% honest, Josh. We're actually going to measure from full extension to full flexion. That's kind of our goal, is to make sure they can get to 0 and go all the way to whatever the range of motion is, or extension, right? We're going to measure them in whichever it is. Here's some of those cool Electro Goniometers. Again, these are really expensive. These are definitely not something you're going to see in our clinic. These things are super expensive. Like the software itself is ridiculously expensive, right? But it measures it with small resistors and capacitors. These things, though, the neat part about these is they have excellent accuracy and retest reliability. What does that mean? That means that the accuracy means they measure exactly what we're measuring, period, right? These are ones that, you measure once, you pretty much have to cut once. They're very, very consistent, right? And then retest reliability means if we test multiple times, the results are going to be very similar every time we test. These cost between $40,000 and $200,000. You're not going to see these in the average clinic. But maybe in a clinic that does workers' comp, you will see these. And why is that? Well, because workers' comp is very specific on wanting really, really accurate measurements. Because 5 degrees may be the difference between a patient going back to work or not going back to work. And not only that, but I'm just going to be honest, workers' comp and private injury pay more. That's just kind of where it is. They do tend to pay a little bit more to the clinic, right? And so therefore, when the clinic gets a little bit more money, they tend to buy new toys. And sometimes we buy toys and toys just sit in the corner and never get used. I'm just going to be honest. That happens a little bit sometimes in the clinics where we spend a good bit of money on this or that device, and then that device never gets used. It's kind of funny the way that happens. It's kind of like buying a tool for your garage, and you buy that one tool that you need for that one specific job, and then once that one specific job is done, that tool just kind of sits there. It's not always the most useful, but it can be useful in certain conditions. And again, most of the time you're going to see these Electro Goniometers in the condition where we're working with workers' comp. We can do radiography and photography or photography for range of motion. I don't see X-rays as often anymore for doing range of motion. I I saw like in the 80s a lot, and the main reason we did it in the 80s a lot is because doctors were trying to make a quick buck. But the downside is, again, every time you get an x-ray, you're putting yourself at risk. I want to say it's a 1 in 150 chance. Don't quote me on that. But I want to say it's about a 1 in 150 chance that every time you get an x-ray is potential for you getting some form of weird abnormal growth, a cancerous growth. I think it's 150. I have to look that up again on break. And then obviously the more you x-ray like critical components like chest and the brain, the higher the risk is for that kind of stuff. So we don't like to do x-rays unless we absolutely have to. Used to be a long time developing the film, but now we have digital x-rays, and most of the time we can get the digitals back right away. Right, that's digital radiography right here. And it may eventually become the gold standard, but I don't see that happening again because of the exposure to the radio waves. We don't typically want to do that. Photography used to be another one that we used a lot in the past to measure range of motion. It is time consuming. But lately, what I've been seeing sometimes is we do traditional goniometry and then take a picture of that traditional goniometry and put it in the patient's chart. So if I'm measuring a patient for shoulder flexion, I may be the one putting the goniometer on the patient and have somebody in the clinic to snap a picture once I have the patient in total shoulder flexion and upload that to the patient's chart. I've had a couple surgeons that really like that method because that way they can see, 0 to 130 may not mean anything to them, but if they, well, it should, but it may not mean anything when they're just looking at it. But if they can actually see what that 130 looks like, it can help guide their plan of care as well. The one nice thing about that is the patient can then also see the change, right? You can show them, look, here's where you were 6 weeks ago. Here's where you are now. So you are getting some progress. I'll say a lot of patients really like to know their goniometer numbers. It's one of those, and it's funny when they say that, but they really love to know their goniometer numbers. It's just amusing to me. Here are some smartphone applications that help get in range of motions. I don't know what these are called, to be 100% honest. These are in the book. But allow smartphones to function as inclinometers with built-in tilt-sensitive systems. These smartphones have just about everything in them. Let me see if where's my, I have a whole, go back to home. Trying to remember what the name of the app is. I have to find it. It's like physics. It's a physics app. Is this what I'm looking for? Yeah, so inside your phone, you have so many sensors in it. There's an accelerometer. There's an accelerometer with gravity, without gravity. There's a gyroscope. So I can bring up the gyroscope in my phone, and the gyroscope will detect the tilt when I'm making changes to the phone. It'll detect if I hold it. I can't hold it still because my hand's shaking. But when I tilt it, it detects those tilts. And so there are all kinds of sensors built right into your phone that are pretty cool. I mean, there's a magnetometer, there's a GPS locator, there's a pressure sensor in your phone. There's all kinds of cool sensors that are automatically built into almost every single phone. And these devices take use of those. Even your camera, I've got one in here that I've used occasionally when I can't find a tape measure. Your camera can be used to measure distances, which is kind of cool. So there's all kinds of little devices inside most modern smartphones now that we don't even use. But unfortunately, right now, the reliability and the validity of these devices is rather insufficient. We haven't tested them a lot in the clinical setting. So we don't have a lot of data on how accurate these range of motions are with the smartphone apps. And then visual estimation. Yields only subjective information in contrast to objective goniometric measurements. This is one I honestly I pride myself on. For the most part, when I look at a joint and I have a patient move themselves through the joint, I can get within 10 degrees just looking at where they're at. just by estimation. It's not recommended. But a visual estimate made prior to goniometric measurements may help reduce errors, right? Knowledge of estimate may influence goniometric measurement results. It can be a visual estimate to see if they're within normal limits or functional limits. It can help us determine if they're severely, moderately, or slightly limited, right? We can even make an estimate based upon whether they have, 0 to 180, or if they've only got 50% of range of motion, 60% of range of motion. The main reason I use my estimation, I'm going to go back here to the goniometer real quick. If you look on this goniometer, there are a bunch of numbers. So we got the red numbers. Oh, let me change that color. Delete, so stick solid. So we got our red number in here, and we got a red number out here. And then we got our black numbers in here. The reason there are these bunch of numbers is it depends upon your starting position and where you're starting. So for example, if I start my goniometer here and I line it up with this 0 down bottom, that's different than lining it up with this 0 over here. So I need to measure off of my exterior angle numbers versus my interior angle numbers, because this happens a lot. So with the ankle, let's think of the way the ankle's laid. Let me get a thicker pen or a brighter color here. So with the ankle, think about the way the ankle is shaped. The ankle is shaped like an L, right? So with that L, it's really hard to start a goniometer where we can get a measurement that lines up. We can do it, but it doesn't always work out that well. So a lot of times when we're measuring that ankle, we start the goniometer out at 90 degrees. Even though that's the 0 point for the ankle, and we'll get to this when we talk about the ankle, that would be 0 degrees of dorsiflexion, plantar flexion. What I'll find is, say you're measuring plantar flexion and plantar flexion, and the foot comes down to here. And that's, say the patient's got 45 degrees of plantar flexion. Some people will get, oh, that's 45 degrees. Other people will say, well, they've got 320 degrees of plantar flexion. And that's where you got to go, oh, well, that doesn't make any sense. That's kind of crazy. Why would they? Yeah, it's the back azimuth, exactly. So you've got to kind of think and go, that's why the visualization and estimate is important. So that if you look and go, oh, I think they've got, so let's look at my wrist here. There's the neutral for my wrist. I'm going to extend my wrist back. What would you say my range of motion estimating for my wrist is? So here to here. Okay, so 80, I'm not quite the 90 mark, but pretty close. Probably 80 to 85 degrees, right? Do the same thing with flexion, but anyway, so that's where you go. Let's say Josh is doing my measurement, and Josh says, okay, it looks like he's got about 80 degrees. But then Josh measures it, and out here's his goniometer, but for whatever reason, his brain locks on that red number. And he's like, oh, he's got 280. Well, that's where Josh uses a little bit of his brain and goes, that doesn't make sense because my visual estimate was about 80 degrees. Oh, well, duh, I'm reading the wrong number. So that's where visual estimates come in handy, is making sure that you don't read the wrong number on your goni. And it's okay. Everyone's going to make that mistake. At some point, I've done it where I've looked and like, this patient has 360 degrees of shoulder flexion. No, they don't. I just messed up and read the wrong number. It happens. Even to the best of us when we're doing things quickly, that's why it's good to kind of keep a brain thought on what your estimation is at the beginning. Yeah, right. So Stephanie's right. So the shoulder of the greatest would be is 180. So 280 wouldn't even happen. You're 100% right. But that doesn't mean that sometimes, for whatever reason, our brains don't lock onto that number and are like, it's 260. It's really strange when it happens, Stephanie. And when it happens, if it happens to you, you'd be like, oh, but no, it's 190. And then all of a sudden your brain's going to go, oh, wait a minute, that don't make sense. Right? And that's where you got to kind of use that visual estimation to help you out. And then we're going to record their goniometric measurements. They're usually recorded in tables or pictorial charts, written text, however it is. The record should provide enough information to permit an accurate interpretation of the measurement. When I am doing SOAP notes, and if I am documenting my range of motion, and I'm going to teach you guys kind of the way I do my SOAP notes, it may not be the way you guys like to do your SOAP notes. That's okay. It's not necessarily the way Dr. Vreskin likes it. It's not the way that Dr. Sokel likes it. This is the way I do mine. And if you turn in your SOAP note and it's not exactly the way I do it, I'm not docking you points, as long as the information's there. That's all I care about. But what I do when I'm doing my SOAP notes is called chunking, right? And what I mean by chunking is I put things in groups. So if I'm doing range of motion, I have a range of motion group. If I do gait, I have a gait group. I do therex, I have a therex group. And then I maybe have a transverse group. I chunk everything into little sections of my SOAP note so that I can kind of fill it in as I go. And this used to be a lot more common when we did paper notes. Now that we do digital notes, it's a little harder for me to do full-on chunking like I used to. But let's say that we're measuring range of motion now. I'm not even going to take, I'm going to get rid of the gait and therex and all this down here. But we're doing range of motion, and let's say we're doing the elbow. So I indicate what joint I'm doing. So I indicate I'm doing elbow. And then I come down here and I'll do flexion, I'll do extension, I'll do right, and I'll do left. So once I've done this, now I'll come in and I've got my little chart kind of, and I could make a grid if I wanted. But basically what I did was I created myself a little grid to put things in. And this is the way my brain works so that I don't miss anything. And a lot of times when I'm walking around the clinic, I'll have a little piece of paper or a notepad that I keep in my pocket, because a lot of times you don't get to your notes until lunch and the end of the day. And I'm not going to remember what I did with my first patient if I don't scribble some notes down. So I keep that little note in my pocket so that I can go back and use that to help me do my documentation later in the day. And I'll do a little grid like this. And I'll say that, you know, maybe the right was 0 to 140. And the left was 0 to 130. Now the extension for the elbow is easy. The extension is always 0, unless they have hyperextension. This patient doesn't have hyperextension. They're stuck at, they end at 0. But that would be the way I would fill out my SOAP note on this, is I would chunk it up like this. If I have multiple joints, well, there's my elbow, and then I'm going to come down here and do shoulder. And I'm going to lay it out exactly the same. So I'm going to put my right, I'm going to put my left, and then I'm going to go down and put the range of motions that I've got to measure with my shoulder. And basically what I'm doing is creating a little flow sheet as I go down. So if I have to measure flexion, extension, maybe abduction and adduction, those are the ones I'm worried about. Then I can go down through and quickly put this on my little sheet. And when I go back at lunch, I have a little cheat sheet I can go back to and easily kind of document what I need to document on the chart. I make little cheat sheets like this for all of my patients throughout the day. Usually in the morning, you know what patients you're going to see, if not the night before. And I'll say this, if you're in a clinic that you know the night before what you're going to see the next day, it's usually a good idea to at least take a look at what your patient looks like before you leave for the day. Because that way you're not walking into a total bomb. It's the first patient. It can be difficult if you're doing like PRN work where you're filling in for somebody. Because I've walked into some PRN work where they're like, oh, McKeever's coming. We're going to give him all the hard patients. So in the clinic, is one able to take a patient and complete a SOAP note prior to helping another patient, or is it required to do it? So it depends, Mark. I try to squeeze as much of my note in as possible while I'm working with the patient. And again, with most electronic documentations, you can start a note and maybe not finish it, and then go back and finish it later, if that makes sense. So I may try to fill stuff in as I'm like, especially if I'm doing the subjective portion. I usually try to put my subjective portion at least in really quick while I'm talking to them. So I'll be like, okay, so how's your pain? How's work going? How's home life going? Stuff like that. And I'm kind of chunking it into my subjective really quick as I'm talking to them. Unless I have to get vitals, and then I get my subjective when I'm doing vitals. But it really depends. Yeah, sure. If the chart allows it, absolutely. There's not a right or wrong way to record the documentation now. Like, as long as it's, that somebody can actually go back and reread it. That's the main thing. Some clinics will require you to write it out as kind of a narrative where you're actually writing a story. And I hate that. I don't want to write, patient today performed shoulder flexion in supine. The right shoulder flexion was this. The left shoulder flexion was, no, I don't like that. That really annoys me. To me, that's a little bit wordy, and all that is there is to make it look like the note's bigger. Yes, Stephanie.
Sorry, it's easier to say than text.
Yep, that's fine.
So then the easiest way is just to go in and get their, like how they feel, like it's like their pain, like, okay, I'm in pain, and it's, what does it feel like? It's dull, it's this. So write all that in, and then leave the rest. Well, you don't have to leave the rest blank, but I'm just saying the easier way would be making your little cheat sheet like you just did on the side.
Mm-hmm.
And later on, you'd be able to go in and just fill in the blank.
Yeah, just fill in the blank, yeah. And a lot of times, once the first SOAP note is done, so once, say that I'm the first person seeing that patient in the electronic health record. A lot of times, once I do that first SOAP note, the first person that sees that patient is kind of the person that gets the pain in the butt, because they've got to set everything up. And then a lot of times from then on forward, you can just copy that note forward and then just make changes to maybe the objective portion of the stuff you do, or make changes to the range of motion measurements. It's not like you have to reinvent the wheel every time you see the patient. That's the benefit to electronic documentation, is you don't have to constantly be writing out everything when you see the patient, because most times it just copies it forward, right? When you open, I open a new note on Stephanie, it kind of pulls all the previous measurements forward so that if I need to edit them, I can, which is kind of nice in a way. But yeah, exactly. You're exactly right, Stephanie. I kind of try to get at least my subjective portion done while I'm working with the patient. And if I can get any more done, like maybe they're on eStim and they're doing Russian. If I can go in and while they're doing Russian, I'm sitting there with them, but still get a little chunk more of my note done, I'm going to try to squeeze in a little bit more of my note as I'm doing that. So there are times in the treatment session when you can do that. That is why Medicare came up with that rule of 8, right? Because if you remember, in order to get 1 unit, you need to see them for at least 8 minutes, right? But technically that 1 unit is really 8 to 15 minutes. So there's a difference there of 7 minutes. This is why Medicare designed the rule of 8 partially, is because what they said is that 7-minute buffer should be where you do your documentation. So let's say I see a patient, they're in for a 60-minute treatment. And the clinic requires me to get 4 units out of that patient. Does anyone remember how many minutes I physically have to be working with that patient to get 4 units? To get 4. Okay, Stephanie's got 53, right? I have to do a full 15, plus another full 15, plus another full 15. Remember, because the first 3 I have to get full 15s. And then the 4th unit I have to get 8 minutes. So that means if I see that patient, I technically only have to see them physically one-on-one for 53 minutes. What Medicare says then is from that 53 minutes to that 60 minutes, that's where I should be doing my documentation. Does that make sense? That's what Medicare says. It's not what the clinics say. That's kind of what Medicare says. Medicare says, hey, look, we kind of give you 7 minutes with the patient to do documentation. But what do you think the downside to that documentation time is in most clinics? Well, the downside a lot of times is you're not only seeing one patient, right? You may be finishing up with this patient and your next patient's already starting. And so that's the downside to a high volume clinic is a lot of times the high volume clinics, you're not going to get your note until midday and in the end of the day. And I have seen clinicians, sadly, especially when I was a director, where I've seen them sit there, their shift is over at 6 o'clock at night, and at 8 o'clock at night, they're still sitting there doing documentation. Because they're not very quick at documentation. And for you guys, I'm going to be honest, the first couple times you do a soap note in the clinic, you're going to feel guilty because it's going to feel like you're holding your CI up. Because CI is sitting there while you're writing out the documentation and they're looking at it and you're like, oh, it doesn't look good. Let's fix this. For the first couple days, that's okay. And during your 2-weeker, it's going to be pretty rare that you get documentation down to a pat, right? You're going to get to do some documentation. That should be one thing all of you want to do on your first rotation is you should want to practice your documentation skills. But you're not going to be perfect at it. And it's not going to be quick. It's going to be one of those learning curves. Even for me, because I'm a little bit verbose in my documentation, I write out a lot more. It takes me a little bit to get all my documentation done, especially if I'm treating kids, because kids' flow sheets don't look anything like adults' flow sheets. I don't know how to document that I did skiing with the kid when it's like they're doing drop skiing. I do different types of fun games with them. There's not an easy way to document that. So I have to be a little bit more verbose in what I do. It takes me a little bit longer to do those documentations. Yeah, they do not pay you to complete them after hours, Mark. No. I'm gonna be honest, they don't. Right, and that can be a downside because, I've been a CI with a student that takes a long time to complete documentations. We understand that as CIs, we really do. That it's going to take you a little bit to get how to do documentation, and so staying to help you do that, it's going to become kind of normal for the first little bit, especially when you're on your 8-weeker. You'll get faster at it, and you won't be holding them up as much. Yeah, I don't like the sound of it either, Mark, but for the most part, usually if you have a good clinic, they build in a little bit of time around lunch and build in a little bit of time at the end of the day for you to do documentation, if you have a really good clinic. I really think this is probably where this whole idea of tech abuse came from, Mark, is because we said, well, if we bring these untrained licensed people, they can do some of our work while we get some of the documentation done. That's where I think it started. I think it started with good intentions. But then they're like, well, we've got more people here, so now we can see more patients, right? And for example, one of the clinics I used to work at, I was expected to see 60 to 80 patients in a day. Yeah. And so think about that for a second. That means I've got a document on that many patients. Or let's say that you're in a clinic that, so do you guys remember what the ratio is? It's a lot of revenue for one person. You're exactly right, Stephanie. So if I have one PT, what is a PT allowed to supervise? Okay. How many total people? They're allowed to supervise a total of 3 people. Right? With a maximum of 2 being any discipline. So I could have a PTA, and a tech. Or I could have, like Josh said, 2 techs and a PTA. Or I could have 2 techs and a student. Or I could have 2 PTAs and a student. The student's the only caveat. The student has to be, you can't have more than 1 student, which I wouldn't want more than 1 student. That would drive me nuts. When I'm working with a student, I want one-on-one time with them, right? But let's just say you're in one of those clinics where they're operating like this. Tech, tech, tech. Because they see that PT can supervise 3 people, so we're going to give them 3 techs to treat patients. So your PT is off doing evals, and your techs are seeing patients. Right? That means at the end of the day, that PT has to do documentation on every single person that tech has seen. So if you figure each of those, yeah, that's a lot, right? So let's, right? I know, Mark. So let's just, and I'm just talking, this is hypothetical. I'm not saying any clinic in town does this. But let's just figure that a PT and each of those techs sees 1 patient an hour. So the PT's got to do an eval for that hour plus 3 notes. And then let's say it's an 8-hour day. So those techs theoretically would be seeing 24 patients on top of the 8 evals that the PT has. So that means that PT has to document on 32 patients in the day. And that's on a, yes, that's, I won't read that out loud, Stephanie, but yes. Yeah, so that's the problem with this, right? Whereas in this case over here, even if this PT is kind of violating the rules and letting techs see patients, at least in this scenario over here, these PTAs are going to do their own notes, right? And that means that this PT only has to worry about their eval and this 1 person, which is a little bit better on my part, at least. I really still don't like that idea, but at least it's a little bit better, right? And the other downside, and very rarely, I know some of you work in clinics, how rare is it for any one clinician to only have 1 patient in a clinic? Yeah, neuro, it's about it, right? Neuro and peds. But even peds, sometimes they double me up. For the most part, you know, there's, unless you're talking about Medicare, there's not necessarily a hard rule. Yeah, like 1 patient an hour, yeah. There's not a real hard rule about how many patients you can see. If you're talking Medicare, how many patients are you allowed to see if you're working with a Medicare patient? Does anyone know? Yeah, 1. Right? Or 1.5 hour if you're doing half-hour appointments. So you can do 2 technically an hour if you're doing half-hour appointments, Josh. As long as you're one-on-one with that patient. You can see 4 Medicare patients at the same time as long as you only bill group for that treatment. And we'll talk about billing sometime later down the road. So technically, Steph asked a great question. Would the PT be responsible for writing the SOAP note for the tech, or would it be a PTA or both? So technically, the only person that can write that SOAP note, if, and again, this is where I really get kind of irritated about this. The only person that can write that SOAP note is the PT, because we cannot supervise the tech. So as a PTA, we are not allowed any supervision ratio. So technically, the only person that can write that is the tech. But I'm going to use, and this is not the way you should be doing things. I'm going to erase all this really quick and show you the way that my clinic operated that I just talked about. So this is the way my clinic operated that I worked at. You had a PT who was at site 1. And he usually had a PTA and then 4 techs. And then here I am over at site 2, because I can work by myself. And this PTA is usually a new grad, because that PTA can't work by himself. So here I am over at site 2, and I'm treating patients. But at the same time, I have 3 techs that are supposedly being supervised by that PT. Supposedly, even though that even violates the rules, right? And so, I may be seeing 2 to 3 patients an hour, and then they're seeing a patient or 2 an hour. And so that builds up. Then I'm seeing 80 patients in a day. Like the most I ever saw in one day was 80 patients. And I did not consider that good therapy because I was basically a circus ringmaster at that point, just pointing people to do stuff. There was no therapy in that, right? But does that make money? Oh, yeah. Oh, yeah. There's a financial incentive to do that, but there's also a financial disincentive because you can end up in hot water for doing that kind of stuff. So long answer short about the whole stuff I was just talking about. Yes, technically PT is supposed to do the documentation on anything that the tech does. Technically, a tech should not do anything for us as PTAs. Yeah, sometimes, Stephanie. Technically, the tech should not do anything for us as PTAs except maybe get the patient, be there if we need a spare set of hands. So let's say we're transferring a 400-pound patient out of a chair to a bed. It's okay for them to be there as long as the PT's in the clinic with us, because PT has to directly supervise the tech and help us transfer patient in and out of bed. But technically, let's say I'm running my own clinic by myself as a PTA, I should only be seeing my patients and there should be no techs in that clinic. Because the minute I have a tech, technically I'm violating the I'm violating the laws. We got off on a little tangent there, didn't we? Sagittal, frontal, transverse, rotational numbers. These are numbers to describe all the motions in each plane, right? This doesn't happen very often. It's not common in the United States. But when we talk about this in the context of like Europe and that, a lot of times they will do all motions in this STFR or SFTR motion, where they talk about what a shoulder does in the sagittal plane, what a shoulder does in the frontal plane, what a shoulder does in the transverse and the rotational plane. And that's how they do their documentation. It's a little weirder, but it's almost never seen in the United States here. So when we're doing goniometries, we use the guide to the evaluation of permanent impairment method to kind of guide us. Usually the main way that we're going to talk about is the AMA. Again, the American Medical Association uses the 0 to 180-degree scale. Now, there's all kinds of different techniques out there for measuring range of motion. There's all kinds of books that give us range of motion, but usually we use the AMA standard for that. Procedures and techniques, just make sure that we've got none of these kind of that cause us problems, suspected or confirmed problems with the muscle, joint dislocation or subluxation, unstable bone, rupture of tendon, infectious or inflammatory process, severe osteoporosis. All of this will kind of be in that documentation when we see the patient. What can limit range of motion? Well, limited range of motion is typically limited mainly by pain. So we need to have the description and the location of that pain. Does the range of motion reproduce the patient's typical pain? There could be structural blocks if they've got a bony block that broke off. Swelling, right? Swelling in the joint, right? That would be joint effusion, or swelling around the joint. That would be edema. Capsular tightness, which we talked about, lack of muscle length. Excessive muscle or adipose tissue. If we got, a big swole bro who's, looks like Arnold Schwarzenegger in his prime, they're not going to have normal range of motion, even though they may be pretty functional. And that's because their muscles get in the way. Same thing can happen if they have a lot of excess adipose or excess fat. Or if their muscles are just too weak to produce the range of motion, right? So when we're preparing the patient for testing here, we're going to determine whether there's contraindications or precautions, determine the joint and motions to be tested, organize testing sequence, gather the necessary equipment, prepare and explain, right? We're going to go through that process again. We're going to give the patient STDs, show, tell, do's, show them what we're doing. We're going to tell them by moving them through the motion and then have the patient move it. Minimize position changes. If we can, we want to get all the position abnormal soft tissue approximation. There's a nice way of putting it. Yes. That is excess adipose. You are correct. There's an abnormal soft tissue approximation at the waist. We want to minimize position changes. What does that mean? If I'm doing range of motion on the shoulder, I want to get all of my supine range of motions done first. And then I may move them into prone or sideline or standing. I want to get all my range of motions in one position done first, and then think through the rest of them. You ideally want to test the unaffected side first if possible. That way you get a good idea of what the range of motion has. Check all of the joints with below normal range of motion or with pain in the motion. Got to note the joint end feel. And then test active. So we're always going to test passive first, and then we're going to test active. So this is kind of procedure. Introduce yourself, explain and demonstrate how the goniometer and clinometer works. Allow the patient to kind of inspect it. Here's my goniometer. This is going to help us check your range of motion. Talk about the landmarks we're going to use, why they need to be exposed, right? Why we need to touch them. Explain and demonstrate the testing position, why it's important. Explain and demonstrate our roles and their roles, and then confirm that they understand. So this is what we're going to do. So that kind of makes sense to you, right? And then test it. Once the patient is okay with it, then we are going to test them. The process is a 12-step sequence. And sadly, this is part of your boards. But the main thing about your boards that they want to make sure that you understand is before you test active range of motion, you test passive so that you can get the end feel. That's the main thing they're going to ask you about this 12-step process. So before you do active, always do passive. So that way you can get your end feels. And also seeing estimate. So position that person, stabilize proximal joint segment, move the distal joint to 0 starting position, make a visual estimate, so move them passively through it. Return the segment to the starting position, palpate the landmarks again, align the goniometer, read and record the starting position, stabilize them and have them move through the motion, realign the goniometer, and measure. The whole time you're going to move, some of your bony landmarks are going to move on you. End feel either closer to 0 or close to the other. So there's going to be an end feel out here on the elbow mark, and there's going to be an end feel right here. So you got to kind of measure both, estimate both of them, kind of go, oh, well, that's bony. Oh, well, that's soft, right? Because I've got my tissue kind of squishing up here. So to make it simple, pick the right size, move through passive, estimate your measurements, stabilize, measure only what you want to, start at 0, and allow for complete movement. And don't get in your patient's way, especially if you're doing abduction, right? Because we're going to do abduction and supine. If you're standing over here to the side, when they do abduction, you're going to get in the way. So you may have to stand at their head in order to get an effective abduction measurement, which is why it's good to stand on a table that you can actually move around in. So why is it important to stabilize the body and proximal joint segments for proper range of motion testing? Because it limits their ability to cheat. And patients may not know they're cheating. Right? We're going to talk about easy ways they cheat for lifting up for shoulder flexion and hip flexion, where they may move accessory motion. But that's kind of the main thing, is to keep them from cheating. All right, let's take a 10-minute break here. Let's stop sharing. And we'll pause recording. All right, so we kind of finished off talking about goniometry. So now we're going to start talking about manual muscle testing. And what is manual muscle testing? Well, manual muscle, if goniometry is measuring the range of motion, manual muscle testing is measuring the strength of the patient. It's assessing the person's strength. It's always assessed relationship or relative to the patient, not to you, right? I may be a ton stronger than my patient. I may be a ton weaker for all I know. But I need to make sure that the strength is relative to them, not to me, right? It doesn't matter if you're stronger or weaker. The measurement's going to be based to the patient. And again, the good news is most of our patients, when we're measuring their strength, they're actually going to have some type of pathology going on. So they're going to be kind of weak. So it's not like you have to have, giant strength in order to overcome and measure their strength. Strength is the amount of force produced by a muscle or muscle group to meet or overcome resistance, right? The first resistance of skeletal muscle most to overcome is gravity before we can start adding other types of forces. And it can be limited based upon many conditions, right? Functional movement requires one or more muscles to act as prime movers and others to act as stabilizers. So why should we assess this? To help gather information, determine whether there's adequate muscle strength is contributing to patient's dysfunction, right? We want to look at the patient's history, their presenting condition, their posture, and their existing muscle length. So we're going to look at those range of motions. And we're going to look at other functional motions or activities, stuff that they do normally throughout the day. And then we evaluate the patient's ability to recruit muscle groups to produce force in a cardinal motion, such as flexion, extension, abduction, stuff like that. All right, so this is the whole scale of manual muscle testing. If you remember last semester, we talked about kind of basic manual muscle testing when you talked about myotones. This is the kind of full scale of manual muscle testing based upon Daniels and Worthingham, which is that brown book that you have that's spiral bound. So there's 5, 4 plus 4, 4 minus, 3 plus 3, 3 minus, 2 plus 2, 2 minus 1. This goes through this whole thing. What I'm going to be honest with you guys is this is typically what you're going to see in the clinic is just 5 down to 0. We'll talk about some 2s as we go through it, but for the most part, your bold numbers are the ones you're going to see most times in the clinic. So 5, 4, 3, 2, and 1. Those are what you're going to see most times in almost every clinic. And then 0, obviously, if they have no motion. These will make sense as we go through them, so don't totally freak out yet. So for our class, in most of the clinics in our area, so I based our class on what the clinics in our area do, we will test on whole numbers only, except for grade 2. Now, some clinics may talk about the pluses and minuses, but most clinics don't because pluses and minuses require a lot of subjectivity, right? Plus and minus grades have been determined by researchers to represent more subjectivity, and they feel is reliably produced by tester to tester, with the exception of a poor grade, too, because there are specific tests for that. A break test is the manual resistance test we're going to apply to the limb or body part after it's completed its range of motion and after it's been placed at the end range by the therapist. We're typically going to provide that break test when the joint is in the mid-range of its motion. The patient has to have adequate strength to achieve and hold that testing position, and then they also are going to have to hold position against resistance from a physical therapist or PTA, right? When we apply resistance, we have to think about, is the joint a one muscle or a two joint muscle? So typically if it's a one joint, we're going to apply it at the end range. If it's a two joint muscle, we'll apply it at mid range, typically. We think about the consistent joint angle and we slow and gradually hold that resistance. So they're going to hold for a 5 count. So this slide is perfect for me because it gives me a little area to write here to talk about the different grades. So if you remember, we talked a little bit about this last semester in biology, but we're adding a few numbers onto this. So I'm going to talk you through the way we're going to do manual muscle testing in the Wnl and Wfl clinic. So when you work with the patient and you are going to assess their manual muscle strength, the first thing you have to do is determine if they can go against gravity, right? So that means they have to be able to move the joint against gravity. For example, the elbow. In order to move into elbow flexion, I have to be able to bring the whole forearm up against gravity. So you're going to tell me, okay, Mr. McKeever, what I need you to do is I need you to bend your elbow and bring it as far up as you can go. If I can bring my elbow up and go against gravity, that is a 3. I'm going to make this as simple as possible. The charts back there are there for you, but I'm going to make it as simple as possible for you. We are always, always, always going to start with that test. Doesn't matter what the range of motion is. Doesn't matter where they were previously. We are always going to start trying to go against gravity. If they were a 2 last time, we're going to try a 3 first. If they were a 5 last time, we're going to try a 3 first. So that means they have to go against gravity. For example, shoulder flexion. We're going to tell them, okay, lift your arm up over your head like this. And we're going to move them through it so they feel what it feels like. And then they're going to have them do it. Okay, great. If I can move full range of motion against gravity, I am automatically a 3. Does that part at least make sense so far? As long as I can go against gravity, I'm a 3. So that's very similar to last semester, right? The top part's going to be very similar to last semester. A 4 and a 5 is where we get into the break test. Right. So it's going to depend on the whole time. So if you're going with elbow flexion in, you're going to apply a resistance in the opposite direction. I'm going to be at my mid-range, so about 90 degrees. And you're going to say, okay, I'm going to push down. You're going to pull up. Don't let me push you down. And you're going to hold. 5, 4, I break. If I hold against resistance, but I break, that means I'm a 4. So if I'm able to give you some resistance, and some clinicians will say it's got to be 2 seconds, some clinicians will say maybe 1 second. Again, this is where a little bit of subjectivity comes in. I typically say if they can hold it for about 2 to 3 seconds, I'll give them a 4. So I'll talk about that in a second, Mark, because we're going to talk about functional versus full range of motion in a second. That's actually, so Mark asked, does degrees come into play? It does, yes, by the book, but not in real life. We'll talk about that in a second. So again, against gravity, good, I've got a 3. Now you're going to provide resistance. 5, 4, I break, that's a 4. Now I come up, you're like, okay, don't let me push you down. 5, 4, 3, 2, 1. And I hold it nice and solid for the full 5 count. That's a 5. And I really recommend you counting out loud to your patient, because if you're just saying, okay, don't let me push you down, and you're pushing, they're sitting there thinking, how long do I have to hold this for? So I can usually count down. Okay, we're going to hold it for 5. Excuse me. 5, 4, 3, 2, 1, and relax. So if they're able to hold it against resistance, against your kind of what I call maximal resistance for the patient, right? Then you're going to get a 5 count. So for those top 3, those top 3 at least make sense. Okay. So Mark asked a really good question about, does degrees of range of motion come into play? Yes, when it comes to the book. The book says if the patient doesn't have full range of motion, they can never be a 3, which is silly. So let's say that you've got a patient that has a permanent contracture of the bicep and has lost, I don't know, 40 degrees of range of motion. even, yeah. Anything against gravity is at least a 1, yeah. But we're going to talk about that in a second here. So even if they lost range of motion, they're stuck. So say they're stuck at 90 degrees. That's all the farther they can go. But man, they can curl 500 pounds at 90 degrees. By the book, it says that's going to be like a 2- because they can't get full range of motion. But are you going to walk up to somebody that can curl, 500-pound weight and tell them they're not strong? That doesn't even make any sense, right? And when you think about it, if you got a bodybuilder who's jacked up and swole and stuff like that, they're never going to get full range of motion because they're going to get soft tissue approximation. So in the clinic, sorry, I thought I had to cough there again. In the clinic, we have to kind of take that into account. Even if they don't have full range of motion, but they got most of their range of motion, we'll consider them a 3, 4, or 5. It really comes into play, especially when we're talking about like amputees, because an amputee is never going to have full range of motion, right? Especially if it's like a below knee amputation, they're never going to have full range of motion of that tibia fibula. And that'd be stupid to say they don't have functional strength if they've got functional strength. Excuse me. All right, so 3, able to move against gravity. 4, you start the brake test, you hold for a few seconds, and I brake. 5, you're able to hold for that full 5 count, and I'm able to resist you, right? And again, proportional to the patient. Because my brake count against Mark might be a little different than my brake count against little old Millie, who's 90 years old, right? Now, Millie may surprise me. Maybe Millie can out bench press Mark for all I know. And if she can, good for her. But the goal is based upon your patient. She's strong, right? Now we get down here into the 2+, 2- and 2. All right, so a 2+ is considered partial range of motion against gravity, full range of motion without gravity. So gravity, what would be considered, I know the book calls it gravity eliminated, but in reality, it's gravity reduced. So let's think about that elbow flexion again, right? If I'm in seated, that's going to be against gravity because I'm pulling vertically, right? I'm moving in that sagittal plane. Man, I must testing in space, exactly, right? So for a 2+, you would ask me, okay, lift up your arm against gravity, and I get a little bit. And then you're going to have to eliminate gravity. And we're going to talk about this for each joint. But how do you think you would eliminate gravity for most of the ranges of motion in the sagittal plane? Lie down in which position? Well, let's think about that. Okay, so I got supine, I got Mark saying side lying. Side lying is going to be the right answer because if I'm in supine, I'm still going against gravity. Does that make sense? Because I'm still coming up into that kind of sagittal plane. I need to almost move it into more of a frontal plane motion. Technically, it's transverse, really, but semantics. So if I go into my side, and I'm now laying on my side, gravity is going that way. So I'm going this way, which eliminates as much of gravity as I can. It doesn't eliminate all of gravity, but it eliminates as much of it as I can. So that's for most of the motions in the sagittal plane. I'm going to move me to sideline. If my motion is in the frontal plane, so here I am and I'm seated, and that's where my motion occurs against gravity. Typically, that I'm going to move into the supine or prone position in order to reduce or eliminate gravity. Angel wings, exactly, right? So for a 2+, you're going to have me try to get a 3. I can get partial. That's just all the further I can go. And then you're going to lay me on my side and say, okay, try it now. And you're like, oh, yeah, I can go the whole way. That's a 2+. Does that part make sense before we go any further down? So 2+ is partial against, full gravity eliminated. A 2 is no range of motion with gravity, full range of motion without gravity. So this is, you tell me to do it in space, and I'm like, yeah, I just can't. I don't have the strength. And then you lay me down on my side, and I'm like, oh, yeah, now I can do it. So a 2, no range of motion against gravity, full range of motion when you eliminate gravity. So no range of motion against, full gravity eliminated. Then a 2- is just partial range of motion, no gravity. So now you test me and seated, I can't do it. I got nothing. You lay me on my side lying, and I'm like, oh, I got some range of motion, but I definitely can't do all of it. That would be a 2-. A 1 is what we call a trace. That's where you put your fingers on my muscle, and you tell me to contract it in whatever position I'm in, and you feel the muscle start to try to contract. That's a trace. Even if it's just a little bitsy contraction, that's a trace. It is better to have a trace than to have nothing. So a 0 means you don't feel anything, you don't see anything, nothing happens. Typically, you're only going to see a 0 when they're de-innervated. So that's an N. So both 2 and 2+ are full range of motion without gravity. You are correct, Alec. It's just a 2+ adds a little bit of range of motion against gravity. Even if it's, 10 degrees, it's something. There's not a hard. So 1 is not against gravity. It's more like twitch. Yeah, so any position you put them in, Mark, whether it's against gravity, whether it's side lying, whether it's supine, whatever range you have them in, if you have them kind of try to contract up and you feel something, that's a twitch. That's a trace. But remember, no matter what we do, even if your patient was previously a 1, right? You're always going to start them here. You're always going to try to get them to go against gravity because you want to give them the chance to be better. Or if they're strong, you may want to have them give them a chance in case they get worse, right? So let's say you had somebody that was a 4 yesterday, but today they can't resist anything. That tells you something. It's all little breadcrumbs we're going to chase in the puzzle of life. So going through this again, you'd say you're testing my shoulder flexion. We always start at a 3 area. You're exactly correct. Always at a 3. So let's say Ariana's treating me and she's checking my shoulder flexion. So unfortunately, she was the last one to post, so she becomes my victim here a little bit. Well, just my tester. And so last time I was in, I was a 2-. She's always going to start me against gravity. So she's going to say, okay, Mr. McKeever, this is what it's going to look like when you move through shoulder flexion. Don't worry about the motions yet. We're going to do each joint individually. This is what it's going to look like. okay, this is what it's going to feel like. She showed me. She's now telling me. So she moves me through it. Okay, can you do that for me? And then she's going to watch me and see if I can do it, right? So if I'm able to get full range of motion against gravity, or most of my range of motion against gravity, I should really say, that means I am a 3. If she gets a 3, her next goal is to now start adding resistance. And she's going to be like, great job. You know, yesterday you weren't able to do that against gravity. Let's see how strong you are now. So now I'm going to have you do that same range of motion. I'm just going to put a little bit of downward push on you. And you're going to try to hold it for 5 seconds. So she gets up on me. She starts pushing down. She's like 5, 4, and I break. That's a 4. If I'm able to hold it the whole time against her resistance, that full 5 seconds, that's a 5. So there's those top levels. Well, let's say that I'm not able to go against gravity. So I'm not able to move full range of motion, but maybe I get 10 to 15 degrees. Her next job, Ariana's next job with me would be to say, okay, Mr. McKeever, let's try lying down on your left side. So I'm lying down, I lay down on my left side, and she's like, okay, now let's try that same motion. And now I'm able to get full range of motion, gravity eliminated, and I had partial range of motion against gravity. What am I now? So partial against gravity, full gravity eliminated. Partial against gravity, full gravity eliminated. I'm now a 2+. Good. Right? So full partial against gravity, full gravity eliminated, I'm a 2+. She starts me in that 3 position and tells me to lift my shoulder, and I'm like, I am. And that arm doesn't go anywhere. She's like, okay, let's move you to the sideline. And if I move to sideline, I'm like, oh, wow. Yeah, now I can do it. Now, if I've got full range of motion without gravity, that's a 2. Because I had no range of motion against gravity, full range of motion, gravity eliminated. That's a dose, 2. If I've got no range of motion against gravity, and I only have partial range of motion, gravity eliminated, that's a 2-. Good, Ariana. And then a trace is just if she was feeling on me and she could feel it. So I'm going shoulder flexion. She's going to be up here on the anterior deltoid. And she feels that anterior deltoid kind of quiver. The levels are designed so that as you move up, it gets more challenging. Does that make sense? Are there any questions about the levels that primarily our clinics want you to know? Yes, no, I love it. That's a great answer, Mark. Good for now. Anyone else have any questions on those, basically those 5 levels? And again, I'm going to keep beating this into you. When we go to when we start on the hip and I start talking about manual muscle testing of the hip, we're going to go through. This is what a 5 looks like. This is what a 4 looks like. This is what a 2 looks like. This is what a 2+ looks like. So we're going to kind of do that for each joint and each range of motion and talk about what they'd look like to you. But a good rule of thumb when you're working with this, I'm going to change my pen color here. Let's go with blue, but let's go with the bright blue. If against gravity, because G is constant for gravity, is sagittal. I think I'm going to spell this wrong, but that's okay. You get my point. Then gravity eliminated is typically going to be sideline. If against gravity, is frontal, gravity eliminated is going to be supine or prone, depending upon the patient. Does that make sense? So let's say I'm doing hip flexion, right? So I'm coming up like this. I'm doing hip flexion. And I can't lift against gravity. You're going to move me into side lying because that's a sagittal motion. You're going to move me into side lying and see if I can do it with gravity reduced or gravity eliminated. If I'm doing hip abduction, coming out to the side, right? Typically, hip abduction is going to be done in standing. So I'm coming out to the side against gravity. I could also do it in side lying, depending upon the patient, if they're not able to hold balance. In order to eliminate gravity, I'm going to put them in supine or prone. That's a frontal plane motion. The transverse or the rotational planes get a little weird. We'll talk about those individually. I'm not going to give you a hard rule for those. But does that make sense for the positioning at least? Are we okay? All right. So what are some contraindications and precautions? Well, contraindications, any unhealed or unstable fracture, we do not want to go ahead and start manual muscle testing them because we could really move that fracture. We could turn an unstable fracture into an open fracture. I've actually seen it before when like patients come into the emergency department and a doctor moves them off the gurney over onto like off the transport bed over to the gurney, where when they've moved them, the bone's gone through the skin then. So you definitely got to be careful if the patient's got that unstable fracture. If they've got a pathologically unstable joint, if they've got something going on where they have a pathology of that joint, you've got to be careful with it. Or where range of motion is prohibited. If they can't do range of motion, we don't want to test their strength. That kind of makes sense. Some precautions. If they have severe osteoporosis, we've got to be careful because it wouldn't be that hard for somebody like me if I put a little too much force and they've got really, really bad osteoporosis for me to snap a bone. Or if they've got something like metastatic bone cancer or something to that effect, it's not going to be that much force to break a bone. Or if they have osteogenesis imperfecta. Do you guys remember that from pathology, what that is? Do you remember what osteogenesis imperfecta is? Not growth plate tissue, that's a different one. I don't know if you guys have seen the movie, but whenever I see this, think of Mr. Glass. Have you guys seen, I think it was the M. Night Shyamalan movie with Bruce Willis, where Samuel L. Jackson's the villain in it? Yeah, Unbreakable, thank you, right? And then I think the second one's Glass, isn't it? There's a follow-up or something like that. And then there's a third one now too, but Mr. Glass in that has brittle bone disease. That's what osteogenesis imperfecta is. It's called brittle bone disease. That means the bone is just really likely to fracture with a small amount of force. And so anytime you see that osteogenesis imperfecta, just kind of think of that it's a guy that's basically made of glass. It's not going to take that much for you to fracture a bone. Right? Those patients are really, really, really weak. So that makes sense that if we're going to work on those patients and test their strength, we have to be super duper cooper careful. Otherwise, we could easily break their bones, right? Even, somebody that doesn't have a ton of force, if they have an osteogenesis imperfecta, it's not going to take much to snap a bone. Oh. So there is a science and an art to manual muscle testing, right? So the science is determining those factors that affect and test our accuracy, knowing the anatomical positions and the biomechanics of a joint. We have to know our origins, insertions, actions, innervations of our muscles. We have to know how to provide stability or counterforce to resistance, and we have to know when they're going to cheat. They're going to compensate or substitute. The art to it is handling those patients that are really injured or poorly functioning. Keep an eye on that patient. Be watching their face, watching their reactions to you. Be gentle when you're testing weak muscles, and then move up in your force as they get stronger. And then apply resistance to allow the patient to provide their optimal force, not to resist your maximal force, right? I'm pretty sure that if Jess wanted to, and she's working in the, she's working in LTAC where she's working with patients that are 90 plus, she could probably go in and do a break test on all of those patients and stop them from getting a 5. She's like, nope, you're not a 5. You're not able to resist me. But it's all the art is knowing when it's to your patient's resistance level, not to your resistance level. So there is an art to that. So how do we do the technique? Well, first of all, we're going to position the patient against gravity. We always start at that 3 out of 5. We move the patient through the range of motion so they know how it's going to do. So first thing I'm going to do is I'm going to show them. Then I'm going to move them. That's telling them. And then clearly tell them what direction to apply force. Push or pull, in or out, up or down, left or right. Be very specific with your directions and try to use single word commands. So maybe say, I want you to pull your arm up. I'm going to push you down. Don't let me. Those are very simple commands that a patient can understand. If you say, I want you to flex your bicep and move your elbow through elbow flexion while I'm attempting to force your elbow into elbow extension, what? They lost you at force, right? So you have to be able to kind of almost dumb it down to very simple terms and saying push and pull, in and out, left and right, up and down, right? Shoulder. I want you to move your shoulder up as far as you can go, and I'm going to be pushing you down. Don't let me push you down. So all of those are important to kind of get a basic. Have the patient move fully through the range of motion, right? Now, understand that according to your book, again, in order to get a 5 out of 5, the patient does have to have full active range of motion, but that doesn't apply necessarily in the clinic. Again, I'm not going to have a full range of motion on my elbow. I'm definitely not going to have full range of motion on my shoulder, probably about 20 degrees short because I have tight muscles. But that doesn't mean that I don't have strength in my shoulder. That just means I need to stretch a little bit more. Have the patient perform the motion again and begin applying resistance about 50 to 75% of the way through that range of motion. If the joint has a bony lockout, such as the knee or the elbow, you have to make sure the patient doesn't get to that bony lockout. So for example, if I am testing elbow extension, if I lock my elbow fully out and I get that bone-on-bone lock going on, you can push me pretty hard and I can resist a lot of force, even though my muscles may not be strong enough. Because that bone-on-bone is going to lock it in place and it's not going to let you to flex that elbow. That's what you're doing because you're going to be pushing against me, right? So remember when we tested the elbow extension out like this, if you remember, I said, don't let that elbow lock all the way out, because if it does, you got bone-on-bone lock, and you're not really testing their strength. So that means you got to kind of lock it out and come off just a little bit so the elbow's slightly unlocked when you're testing it. The knee is a similar thing. We're going to talk about the knee having this mechanism called the screw-home mechanism. And what that means is when that knee extends, right? That little bit of protuberance on that tibia is eventually going to lock into that femur. And it's going to screw home. It's going to lock into place. If that knee is in full extension, I may be able to use that bony lock to resist your strength versus my muscles and my quads resisting you trying to flex, push me into flexion. So you have to get them out of that unlocked position. You're going to apply the resistance in a firm and consistent manner, remembering you're testing the patient's strength, not your ability to break the patient. And then you're going to record those numbers appropriately. What could cause considerations or factors of consideration for me in muscle testing? Muscle substitution, right? If you see me kind of hiking my shoulder when you're testing my range of motion, I'm trying to cheat. If you see me hiking my shoulder when I'm trying to do elbow flexion, I'm trying to recruit my stabilizer muscles to resist my force, right? You want to test for palpable contractions in minimally active muscles. Typically, when I move them through that 3, when I have them go through that 3, I'm going to put my hand on that muscle I'm testing because I want to get a good feel of how that muscle is actually contracting. That also tells me if I don't get any motion, do I at least have a 1? Because if I test it first off and I'm testing that 3 and I get my fingers on them and like, oh, I felt that twitch. I've already got my 1. I don't have to test it later on. Think about fatigue. There are times to test our manual muscle testing after therapy, but those are few and far between. Most of the time when we do our manual muscle testing, you want to do it before they start their therapy. Think about that for a second. If, Josh, Jess, and Stephanie all go to the gym and they work out super hard and, they get themselves to where they're just fatigued out. And then I come over and I'm like, okay, I'm here to test your strength. They're going to be looking at me with screw faces going, we just worked out. What are you talking about? Right? That doesn't make sense for the patient most times. Now, if we have an athlete, we may be testing that. We may be testing to see how their strength is after they've performed. That just depends upon what our goals are. But for the most part, we're going to test range of motion and strength before they do any other activity. Be consistent with testing. The patient has to be honest with you. If it hurts, they have to let you know. Be aware of language barriers, right? If they don't speak English, that's a problem. If they can't hear you because they're deaf, that could be a problem. You have to be aware of those language barriers. And then also be aware if they have limited range of motion, right? If they already automatically have limited range of motion and you tell them, lift your arm way over your head, it's kind of mean. Ouch is universal, yeah, right? And I can usually look at somebody's face and tell if they're in pain. There is a universal I'm in pain face, right? That's that Wong-Baker scale. So just be paying attention to your patient. Doesn't always mean you're gonna, I've had patients that speak only Spanish. And Mr. McKeever, nah, Español, no bueno. I do not speak good Spanish. But I've been able to do full treatments with them because I'm able to get across what I need to either by pantomiming or by providing them with documentation in their own language. And also the Google Voice Assistant or the Google Translation Assistant, phenomenal. I use that a lot. I've had patients where they speak Polish. There's not a Polish translator in the hospital usually. So you may have to use something like that. Some of the new techniques that are coming out, I really want to test. There's a new earpiece that they have that when they speak, it translates it into your ear. It pairs with your smartphone, which is pretty cool. And then you can speak, it detects what you're saying, and it'll output it through your phone what you're trying to say. Babbel does it, I think, to your right. But it's just really interesting when you do stuff like that, that we're actually technology where back in my day, when I did all this stuff, we had this thing called the language line, and this was fun. The language line, do you guys know what telephones are? Because it's a telephone. And it had 2 receivers. And you would pick up the language line as a clinician and say, I need somebody that speaks Bulgarian, right? And they would get somebody on the line that speaks Bulgarian, and then I would hand them their receiver, and I would say what I want to them. The translator would then translate it to them. They would say what they needed to translate it, and the translator would translate it back to me. So basically, it was a can in a string, Mark. It was really a can in a string. And those sessions got to be long. So reliability, can we trust these tests? Yes, the minimalist testing are very good, but what can throw them off? Well, can it be repeated by the same person? Does it have intra, meaning between me, and intra-rater reliability? Is it safe? Does it show what I need it to show? And can it be repeated by other people? Sure, right? Manual muscle testing is a intra, meaning between me, and inter-rated reliable and valid test. We've tested these over and over again. There is a statistical acceptable variability in both manual muscle testing and goniometry. That just happens. So when you're looking at manual muscle testing, it's priority when you're gathering information about soft tissue injuries, source of dysfunction and stuff like that. When they have functional deficits, when you're going for a natural progression from a range of motion assessment. It's pointless to get manual muscle testing when there's a contraindication of a muscle contraction. They're in high levels of pain, or you're unable to isolate motions in cardinal planes. They're unable to do specific one type motion, one arc motions. It's pointless to get at that point because we have no measurement. Now, the good news with manual muscle testing, I'm going to talk about this before I let you go, is we're getting I think in the next probably 2 years or so, I think manual muscle testing is actually going to go away. I really believe that because, well, not the skill of manual muscle testing, but the subjectivity of 5, 4, 3, 2, 1, 2 plus, 2 minus. Because we now have handheld, this is not one, but there are now things called handheld dynamometers. And these are force plates that usually pair up with a computer or with a smartphone. And we can put that force plate on their forearm. And as they contract up, it gives us a level of force that they're able to generate. That is, yeah, it is cool, right, Mark? That is a much more objective number, right? And we can see greater gains that way because we could actually see force gains. And I think by the time you guys are really kind of out there and final, real clinicians, I really think that will be the norm to it because they're becoming a lot more inexpensive and they're becoming handheld. I'm trying to order one right now that literally it just slips on your palm like this. And you can test pretty much every muscle with it that you want. And it gives the patient a force reading, which then can be imported into their what do you call it, their chart, and boom. You don't have to do the subjective 2 plus, 2 minus, 1 plus, whatever, right? It's just, it is Mark generated 225 pounds of elbow flexion. And it gives us a good solid number that they don't even have to worry about. That's gonna be that's a good elbow flexion there, Mark, let me tell you. You can curl 225 pounds. We can see some real gains, you're exactly right. All right, are there any questions from today? So great question. So Alex says, on the schedule for this class or maybe Therex, there's a reading section to a chapter of the book of the fundamentals of orthopedic management. That book is actually a classroom book. I'm going to provide you, I just reference that chapter, Alec. I pull everything out of that book for the PowerPoints. I'm pretty sure it's in Therex, actually. You're right. So you don't have to necessarily read that book. That is a book that's in the classroom in case you want to use it. I use that a lot for case studies because it's got a ton of case studies in it. So you don't have to go read that book. It's called the FOM. But it's a good reference, especially if you guys, I don't know if you guys don't have reports this semester, I don't think. I'm not making you do one. I don't think Dr. Sokil is either. But next semester, you have a report for Dr. Reskin, and that's a really good book to get some reference material out of because it's got a lot of like case studies and stuff like that that you can kind of reference. So I use that a lot for my case studies. So when I'm talking about stuff in Therex, I'll reference that chapter out of the book if I've taken something, because I have to reference where I took that material out of. Does that make sense? So for you, primarily in Therex, the green book's your main book for that class. And then for this class, your main books are your original kinesiology book, your goniometry book, and your manual muscle testing book. Anyone else have any beast mode questions? You guys ready to go? I mean, I'm hoping I can be back on campus next week, Stephanie. If not, you guys maybe. And I may not be. It just depends upon if I can get cleared. I don't want to come in and bring it into you guys, right? I'm trying to think of you guys as well. And the main reason is we ended up with not only so many out in your cohort, but we ended up with a bunch out in cohort, what's the other cohort? 12. I think what number they are. We've got like 5 out in cohort 12. And so we wanted to sterilize the room as well. And I can't really do that with you. Well, we can't really do that if you guys are in the classroom. That would be bad to spray chemicals all around while you're in the classroom. Even like the day after, it kind of burns a little bit. So we're trying to get them to really kind of sterilize the classroom for us so that you guys don't get sick. But potentially potentially the goal for our campus director and for Dr. O'Neill is to be back next week. Yes. That is the goal.